what is too early when the patient is not hypoxic in the first weeks of illness. But by the way, actually, in determining the patients whether patient is in the first week or second week or third week, actually it's not really accurate due to the symptoms that can be subtle. So and other things not to be given, other things whereby the steroid not to be given too early is when the patient presented with low CRP and low NLR. But bear in mind, sometimes the patient with full-blown hyperinflammatory response also getting a low CRP count as well. So that's why we complement it with doing ferritin and also LDH level. So watch out for complication of steroid also, which includes upper GIT bleeding, hyperglycemia, haywire of glucose basically, superimposed infection, and also patient developing muscle weakness. And steroid also can be harmful in the late disease. For CAT 4A and 4B, 5A and 4B, basically we are talking about giving steroids therapy and also consider antiviral if available, plus steroids, and if worsening to escalate the steroids choices. For CAT A, for example, we are actually talking about giving DEXA, metazone depending on the BMI, and consider antiviral. The one that we have in our ED is the one that we have in our hospital is favipiravir. We don't have remdesivir, by the way. And also, if worsening, to escalate to IV methylprednisolone. For CAT 4B and 5A, actually, we are talking about giving IV methylprednisolone for 3 to 5 days and step down as soon as we saw the patient actually improve. And consider antiviral if available, which actually generally less than 10 days of illness plus IV DEXA. And within 14 days, if the patient is having a CRS, we can actually give the patient steroids plus immunomodulator IL-6 or which is a tocilizumab or baricitinib. Okay. But having to say that actually the immunomodulators for us in our hospital, we have limited amount. So actually, if we want to give those immunomodulators, we have to discuss with our IED and also our anesthetic colleague. For 5B category, we are talking about IV methylprednisolone, and to step down if the patient improve, and to consider steroid plus immunomodulators. Antiviral is no more recommended in category 5B. Okay, other recommended treatment of COVID-19 are including patient's oxygen requirement that we will learn about in today's webinar, particularly in NIV. And we also have to address hypercoagulability. So we need to actually give anticoagulant, whether it's a prophylaxis dose, high prophylaxis dose, or full anticoagulant in a patient with pulmonary embolism or thromboembolism. And also cover the patient with proton pump inhibitor and select carefully the choices of fluid therapy. And when we are doing monitoring for the patient, we are monitoring the vital signs and the frequency is depending on what category of the patient in, and also regarding doctor's reviews. Basically, we want to see symptoms improvement, respond to therapy, warning signs, and further intervention whether it is needed or not. Okay, this is basically an overview of a general approach for COVID-19 patients in emergency departments and bringing up to the primary team when the patient will admit to the ward. Okay, so now I finished my talk, 20 minutes. So I would like to invite Dr. Azlizawati Azil. She's actually an emergency physician and also a emergency critical care and also we focus ultrasound fellow in Hospital Raja Permaisuri Bainun. She will be talking more about COVID-19 management, the extra tips for all of us. Okay. Without further ado, I invite Dr. Azlizawati.
Hi, Assalamualaikum warahmatullahi wabarakatuh. Thank you, Dr. Sabrina, for the comprehensive presentation. So I'm just going to share my screen. Kenapa saya tak boleh nak share? I want to get rid of this. Right, can everyone share see my shared screen?
Yes, crystal clear, Dr. Azli.
Right, sorry about the delay. Right, thank you, Dr. Sabrina, for the comprehensive lecture. So my presentation is a COVID-19 management extra tip. So basically just a continuation from Dr. Sabrina presentation. Okay, this is an outline of my presentation. We're going to talk a bit about COVID-19 pneumonia. We're going to talk about the key point or keynote in terms of approaching our approach to manage COVID-19, especially those that need NIV. So key point number one is to support oxygen requirement. Key point number two is to control host hyperinflammation. Key point three is to monitor patient. And key point number four is organ support. But not all I'm going to cover because some of the topic going to be covered by other presenter later on. Right, so this is a famous quote, right, by Sun Tzu. Know your enemy and know yourself, and you can fight hundreds of battles without disaster. So it's basically summarize well our struggle in order to fight this battle of COVID-19 pandemic. All right, so I think you are quite familiar with this diagram Dr. Sabrina already showed to you. So what I want to highlight is that basically to make it simple, in terms of knowing the progression of COVID-19, we have stage 1, stage 2, and stage 3. But in this series of webinar, we are basically interested in those patients who are in stage 2, which is the pulmonary phase. So majority of COVID-19 patients, about more than 95%, will be categorized in stage 1. So this is an early infection where they have this mild predominant symptom like Dr. Sabrina just mentioned just now, and they will get better and cured. But some of them might progress to stage 3, and some even little will progress to stage 3. So it is most important for us to recognize and aggressively treat those patients in stage 2 so that they won't progress to stage 3, which is the hyperinflammation phase. So it's our job to, our concern is basically at the stage 2 primary phase of the COVID-19 disease. So to talk more about COVID-19 pneumonia, Gattonini and colleagues have come out with a theory or basically explanation because COVID-19 pneumonia is a bit peculiar. To highlight this, okay, have a look at the CT slide at the above there, right? You can see that's quite normal, very minimal consolidation. Majority of the alveoli is quite well. It's dark in color, black in color, meaning that it's well aerated. Compared to the CT scan below, which is you can see that all white, a very minimal black area, which is indicate the well aerated lung, which is only minimal at the anterior top of the chest. So this is belong to two different COVID-19 patients, but you can see the very contrast, a huge contrast of the CT appearance. But what's surprising is that the PF ratio, both of these patients are less than 100 mmHg, which is considered already a severe hypoxemia. So Gattonini and colleagues have come out with these two different types of phenotype to explain this peculiarity of COVID-19 pneumonia. The first one is, they call it an L phenotype. Basically, due to pulmonary vasculopathy because of the loss of hypoxic vasoconstriction and also maybe thrombotic microangiopathy causing this severe hypoxemia, compared to the H phenotype, which is basically already diffuse alveolar damage due to the edema, inflammation, fibrosis, which is follow the normal pattern of ARDS that we usually known to. So this is the two phenotype to explain this peculiarity of COVID-19 pneumonia. But in reality, these two phenotypes do not exist as a separate entity. It's more like a spectrum of the disease. It could be a progression of the disease. So initially, maybe this patient might present it as an L phenotype and later on develop to H phenotype, to the full-blown ARDS. This could be because of the worsening of the disease itself, worsening of the host hyperinflammatory responses. It can also induce by the patient themselves, what you call as a PCL, patient self-induced lung injury. So normally when patient is not properly supported their oxygenation, they might breathe rapidly and breathing huge amount of tidal volume. So this rapid and huge tidal volume can give strain and stress to the alveoli and cause inflammation and injury to the alveoli. So progression of from L to H type. Really ventilator-induced lung injury also when we not adhere to the lung protective strategy. All right, we basically a low tidal volume, driving pressure of less than 15, P plateau of less than 30 mmHg. So not adhering to this can lead also from L to H phenotype. Other factors like secondary infection, aggressive fluid therapy also can worsen this COVID-19 pneumonia. All right, so let's take this case scenario just to go to our presentation. A typical case we normally have nowadays, right? Let's say the patient name Mr. Yo, a 56 years old gentleman, smoker, hypertension, not vaccinated yet, day 10 of illness, ambulance call for worsening of shortness of breath during his house quarantine. So on arrival at home, the paramedic noted that he is very tachycardic with a low SpO2 of 92%. So definitely they give him oxygen support of 10 liter face mask. It helped a bit, but patient still tachypneic. So on arrival at your emergency department, right? So the doctor saw him and it is not on the 10 liter of oxygen. He is still tachypneic, still tachycardic, and also low in SpO2. So the decision to give high flow nasal cannula was taken, and it improved him. Right, the SpO2 raised more than 91%. RR is less tachycardic, less tachypneic, and the BP seemed to be normalized. All right. So are you happy? Are we happy with Mr. Yop's current treatment? He's on high flow nasal cannula, 50-50, so 50 liter per minute, 50% of oxygen. Pretty much better. RR not so bad, mild tachypneic, heart rate normalizing, BP normalizing, but the SpO2 just hovering around 92%. So is there anything else we can do for him? Do we increase his oxygen support? Do we change him from high flow nasal cannula to NIV? Right, so anything else we can do? So tips number one that we can try is for awake prone positioning before we try to escalate the oxygen therapy for him. Right, so awake prone position, is it applicable to be, is it feasible to be done? Right, this one study done in Italy, right, they have found out that yes, it is feasible. The set of patients that they try awake prone position, they able to achieve at least minimum of 3 hours, and they also repeated this prone position 3 to 4 times a day. And what most important is that they definitely they saw a significant improvement in terms of oxygenation, which by the PF ratio is improved. And basically the oxygen delivery interface that they're using basically from helmet CPAP to mask and to from venturi mask. So some of us might think that prone position is a bit difficult and not feasible if the patient using helmet, but this study have shown that it is feasible. All right, so why do we do prone positioning? How does this prone positioning help COVID-19 patient in terms of their oxygenation? Well, theoretically, let's imagine the patient is lying supine, the normal position that usually we ask the patient, right? So normally with the patient lying supine, okay, lying supine here, you can see that because of the gravitational effect, right, gravity pull down. So majority is it at the dorsal side or the back of the patient body. Majority of the alveoli tend to collapse, right? Tend to collapse because of the effect of gravity, but at the anterior part of the chest seem to have a good expansion of the alveoli, right? So what happens is that most of the time, all right, usually normally the perfusion is very well at the dorsal part. So that's why you have a VQ mismatch in supine region. Okay, remember just now I told you about the L phenotype by the Gattinoni groups. So this is due to vasculopathy, all right? So this can contribute to the worsen of the oxygenation. Now, when we ask the patient in a prone position, right, we expect that, right, the alveoli that is collapsed because of the gravity effect now is on top, basically at the anterior part of the chest. So with this, with less of gravitational effect, we hope that this part of alveoli, right, will be recruited. Okay, do remember that at the dorsal part, right? So the vessel, the pulmonary vessel, will have a good perfusion, right? Now you will improve or reduce the VQ mismatch, meaning that you have a recruited alveoli and you have a good pulmonary perfusion. So will we expect to have improvement in terms of oxygenation because we reduce the VQ mismatch. So that's the theory of prone positioning in ARDS or even in COVID-19 patient. So what is actually the indication for awake prone positioning? So number one, of course, acute hypoxic respiratory failure, which need any oxygen supplement to maintain the SpO2 at least more than 92%. The patient need to be able to follow the instruction and hemodynamically stable. So I think go back to our Mr. Yup, our patient, right? He is alert, the vital sign is stable, the SpO2 is low, 92% despite on high flow nasal cannula. So I think he's good to go for our awake prone positioning. So before that, just a quick checklist. What are the contraindication of awake prone? So number one, any sign of respiratory fatigue, right? Either R2 tachypneic, the PCO2 is increasing, there is a metabolic respiratory, and there's a accessory muscle use, right? Number two, profound hypoxemia, right? Number three, required immediate intubation, which is example patient is unable to protect the airway because of vomiting, lot of excretion, etc. Altered mental status, unable to cooperate, right? Patient is agitated or refuse, right, to turn and comply to the awake prone positioning, or anything that you think can harm the patient, for example, morbidly obese, spine problem, or any recent surgery to the chest or the abdomen wall. So these are basically some of the contraindication that you need to think to ensure a safety for doing awake prone position. Right, so when we talk about prone positioning, we always think about the patient who are intubated, mechanically ventilated. So this kind of patient who is an invasive mechanically ventilated patient usually need to be deeply sedated and paralyzed in order to perform this prone positioning. So when this patient deeply sedated, paralyzed, this patient normally don't have much say or choice in terms of how they're going to be prone or positioned, right? So it's different in an awake prone position because the patient is very much wide awake and they can talk to you, right? So basically we can have a multiple or variation in terms of prone position. For example, picture number 1 and number 2 is the true prone. Okay. Number 3 picture, you can see there's a modified prone. You can see a bit like a swimming position, your freestyle swimming, right? Swimmer position, what we can call it. Number 4, the patient can be sitting upright. Number 5 and number 6 is basically a lateral position, either left or right. So there's a variation in terms of in the awake prone position. So how do we go by this? All right, how do we go by this? So the first one, we need to have a bed preparation for this, right? We need to have a suitable bed. Basically, the size should be well according to the patient, right? And ideally, we need a few pillows, right? Soft, comfy pillows. So basically, one pillow to be put under the head, 2 pillows under the chest, 2 pillows under the pelvis, and 1 pillow under the shin, right? If somehow we don't have this bag, alternatively, we can have roll towels or blankets, right? See, this, if you have a nice pillow, it's much more comfortable for the patient. So what you need to make sure that there is a good gap between the chest pillow and the pelvic pillow for the abdomen to be free, hang loosely and free and not be compressed, because you want the diaphragm to move freely and not obstruct or basically interfere with the patient breathing. We also need to make sure that the sheet creases, maksudnya ada kumpulan-kumpulan, we don't want that, right? Should be minimized between the gap of the pillow, right? We don't want the patient to have a pressure sore or a mark because of the creases. The bed then, to add on more comfortable to the patient, right? The bed should be able to be positioning in a reverse Trundleberg at least of 30 degrees, if possible. Number 2, we need to prepare the patient, right? So patient is full awake, right? Need to be able to obey commands. So we need to explain the patient why do we need to do this, the benefit of it, so that we to increase the patient compliance to the prone position. We at least need 2 assistants who to assist this and to make sure this is a safe procedure. So ideally on the left and the right side of the patient. We to secure the IV lines, right, to make sure everything is secure well, right? And then the assistant need to temporarily disconnect any IV drips and monitoring device from the patient for assist the easy turning for this patient. Okay, number 3, when we position the patient, right? So of course we ask the patient to turn himself or herself. The assistant need to supervise this turn. Okay. After the turning, right, make sure that any nasal cannula or mask is still fitted correctly on the patient. Ask the patient to head rest on the pillow and turn the head slightly either to the left or the right, and make sure that the cheek is basically comfortably contact with the pillow. Ask the patient to raise his arm above the head, and then we slide in the pillows below the chest, pelvic, and the shin, right? And at the same time, we encourage and allow the patient to adjust himself to get more comfortable. And ensure that the abdomen is free. If this is unable to be achieved, maybe we need to consider to add on pillows over the chest and also the pelvic. Okay, and lastly, check for any pressure points, right? Ask the patient, is the patient comfortable? Okay, reverse the bed into the Trundleberg position, and then reapply back the monitoring devices. So we will ask the patient to remain in this position as long as the patient tolerated, or we change the patient every 3 to 4 hours with allowing a time break so that the patient can eat, drinks, use toilet or anything to just relieve the pressure area. Please follow your department awake prone position protocol if you have one. Okay, this is another alternative position that you can ask the patient to lie. All right, you can put the pillow over the abdomen at the back to add comfort, or you can do the position at the tree space, basically, as long as the patient comfortable and agree to do it. All right, it's the best. So there is some protocol mentioned that this awake prone position cycle, whereby we change the position of the patient every 30 minutes to 2 hourly. Okay, but currently there is no strong evidence to suggest any certain optimal proning method or protocol. So in my opinion, as long as the patient is comfortable, right, that's the best position for that patient. So again, any position is better than lying supine. So do encourage your patient, especially COVID-19, to change position and minimize their time lying on their back. Okay, so that's key point number 1 completed. Now we go to the key point number 2. Right, I think this the one Dr. Sabrina already mentioned just now. I just going to go slightly brief. All right, so regarding this, This is recovery trials, right? So this is the one, and I think this is one of the trials that confirm and show that steroid do have an effect, improve the outcome of COVID-19 patient. All right, so these recovery trials basically emphasize on the stage 2, right? So what does these recovery trials summarize? It says that yes, dexamethasone reduced COVID-19 pneumonia mortality in invasive mechanical ventilated and those who require oxygen supplement, but no benefit was seen in the patient who does not need oxygen supplement. So basically, steroid is meant for the stage 2, right? So once the patient needs some sort of oxygenation, it could well in terms of that the host hyperinflammatory response has already just kicked on. So that's why this kind of patient that will benefit more to receive a steroid rather than in stage 1, where it might impair the patient innate and adaptive immunity to fight the viral. Okay, if we give too early steroid at the stage 1, it might cause a higher viral replication, and it can be have a detrimental effect on patient. But if we to give steroid at the stage 3, it seems to be quite late already. We missed the boat. So stage 2, this is the stage where we really want to aggressively treat and monitor our patient. So this is the best window to prevent COVID-19 pneumonia to go on to the stage 3. So again, I think one of the questions by the audience, methylprednisolone and dexamethasone, which one is better? Okay, this study, all right, even though it's a retrospective, small single-centered study, what they find out that actually in the mechanical ventilated COVID patient, right, methylprednisolone can lead to further mortality reduction compared to dexamethasone. Okay, but if we do given methylprednisolone to patients that require only oxygen, there's not much difference. So methylprednisolone is reserved basically for our mechanical ventilated patient. You can base on this small study, but theoretically, yes, methylprednisolone is said to have a better penetration of the pulmonary tissue. Okay, that's why we tend to reserve it to the most severe COVID-19. But the question you guys might ask, why cannot we give methylprednisolone to those who require only oxygen? I don't think any harm, but sometimes it will depend on the availability of your drugs. So you need to choose your drug also for that. So if you can see from this study, by giving DEXA, right, for those who need oxygen, there's not much difference, okay? Then why you want to waste your resources to give metapred to this less severe patient? So you should reserve this metapred for those who are more severe. So I don't have any direct answer for that, but we base on that, right? So yes, methylprednisolone has a good lung penetration, but again, your choice of medication will depend much on the availability and your resources, right? So why waste if it's in the oxygen, the benefit is the same. Might as well use DEXA and reserve metapred for those who are severe needing mechanical ventilation. Right, so this is summary. I know some of us might be confused. I also last time quite confused on when to start, when we want, which type of steroid we want to use, what dose. Okay, this is to summary, right? When the patient does not need an oxygen, no steroid, right? No steroid. But when they start to have hypoxemia and need some sort of oxygen therapy, yes, IV DEXA, 8 mg or 12 mg, depend on the body weight. As the patient worsen, right, need more oxygen support, right, let's say high flow of oxygen, NIV or intubated, switch to IV methylprednisolone, right, because of better pulmonary cell penetration. And let's say, despite on this high dose of methylpred, right, this your usual 2 mg per kilo, the patient still, all right, not improving, all right, you think that the patient still having a hyperinflammatory response, Then another choice is that we can use a pulse dose, meaning a higher dose of IV methylprednisolone between 250 to 500 milligram OD. But again, this pulse dose, we do not have enough evidence to support or against it. So after discussion with the team and also maybe your intensivist or your ID physician or your physician, then you can optimize the steroid. Right, key point number 3, patient monitoring. Okay, I don't want to touch much because I think Dr. Azma will cover most of this. Okay, but why we important? Okay, again, remember our Mr. Yop, right? He is stranded in ED. Normal scenario happen in our Ipoh emergency department, right? Okay, now day 3 of in ED. So we noted that the patient become more tachypnic, SpO2 worsening, despite our good effort increasing the flow and the FiO2. So what can be happening to him? So differential diagnosis that you need to think of, okay, progression of the COVID-19 pneumonia, secondary infection, right, day 3, right, so highly chances of nosocomial infection, pulmonary embolism, right, the COVID pneumonia tend to have a microthrombi, fluid overload, right, worsening of cardiac function, and maybe pneumomediastinum of pneumothorax because of infection or because of the COVID-19 pneumonia itself. Right, so just to a bit of extra tip, all right, your FBC, all right, just want to highlight that normally in the FBC we only see HB, fat dead, and white cell. So this is add-on value where you can count neutrophil to lymphocyte ratio. So how do you do this? So basically you just get the absolute number of neutrophil divided with an absolute number of lymphocyte. Anything more than 6, right, will trigger you is an abnormal. It could be an early warning sign of a severe COVID-19 infection. This NLR basically is not specific to infection or inflammation, but it more correlate with physiological stress. So you can use it as a early warning signal for a severe COVID-19 infection. Other tips, okay, to see the progress of the patient, your inflammatory markers, right? So these inflammatory markers do have a correlation to associate with a more poorer outcome, right? And other committed disease marker like your D-dimer, procalcitonin, pro-BNP, right, can help you to direct which type of management that you we would like to take along with the normal COVID-19 pneumonia. All right, and lastly, key point number 4, right, is to summarize. Okay, remember that your patient is not a robot. Okay, make sure your patient is comfortable. The patient might need analgesia, might need some anxiolytic. Okay, remember the feeding. Right, this patient still need to be fed. Okay, have a make sure the glycemic and the BP control is well controlled. Okay, be specific and be scrutinized. Scrutinize the fluid input and output of this patient. Right, so if we give too aggressive fluid, the patient might end up into an ARDS. Okay, remember the underlying comorbidities. All right, make sure the medication, the care is geared up to supporting these comorbidities. And last but not least, all right, remember this patient needs some sort of physiological and also emotional support. All right, so with that, I end my presentation. So I think for the next speaker, we'll be having Dr. Muhammad Faiz Bahiran. He will present on NIV in COVID-19, the do's and the don'ts. So with that, I let Dr. Faiz share his screen. Thank you. Faiz, sana sekali kat sini.
All right, Assalamualaikum and a very good afternoon to everyone. And hopefully everyone is still staying strong in this pandemic. I'm Faiz and I'll be continuing the talk on NIV in COVID-19 with the do's and don'ts and what we should do and what we should not do with regards to NIV use. Here's the outline of my presentation, some introduction and the evidences of NIV use, and then we'll talk about the do's and what is the big don't and some take-home messages and references. This is the to-do list that I would like to emphasize in this talk. Number one, do familiarize yourself with the basic of NIV, its basic function, how it works, the basic settings. And number two, do choose the correct interface for your patient. Number three, do acknowledge the risk of transmission so that we can come up with a strategy to combat the dispersion. And number four, I think Dr. Hazli has talked about this, do consider awake proning, and I will re-emphasize on this. And last but not the least, but most importantly, do implement monitoring to all your patients. All right, with regards to the to don't list, a guide to not doing, I have only one big don't, which is do not use your NIV with the aim to delay intubation to those who are in imminent arrest. All right, let's start off with some introduction, shall we? We know that the story all began in Wuhan, capital of Hubei province in central China in late December 2019. And little did we know that time that human race would be facing life-changing crisis thereafter. And at that time, early reports suggest early intubation, no NIV use, and intubation was advocated early. However, problems began arising with the surging numbers of patients. We have very limited ventilators, and weaning the patient off the ventilator is easier said than done. So we have to actually rethink the whole ventilation concept to cope up with these issues. And addressing this problem is of paramount importance to cope up with the global threat. Yeah? Since it is a new thing, the pathophysiology is very difficult to understand. And as we know, COVID ERDS can present with different phenotypes from very mild to very severe form with variable lung compliance. And from this, we can extrapolate that the disease itself is heterogeneous. And no matter how you look at it, no one size will fit everything. Hence, we are in urgent need of RCTs globally, including NIV RCTs. So now let's have a look at the evidences. So this is the meta-analysis on the use of NIV in COVID-19, in which its aim is actually to appraise the quality and availability of guidelines, whether NIV has its role in this pandemic era. So basically, they downlisted 26 guidelines from international organization, North America, Asia Pacific, and others, and they extracted 138 recommendations. And basically, they touch on these four main domains: safety issues, the installation, indication, and parameters and settings. However, we can see from this yellow box that some of the guidelines provide some sort of strength of recommendation and quality of evidences, but many were also ungraded. Yeah? So with regards to the evidences of NIV use in COVID-19, this is a new thing, not fully understood, but we still have some evidences from the RCTs. And of course, we are in urgent need of well-designed RCTs to solve the unresolved debate that is ongoing. So the next question would be, is HFNC considered NIV? Like in this old picture, we can see that there were groups of people on the same table. They were talking about something different, this side and this side. So with regards to HFNC, we have different school of thought too. Some say HFNC is not NIV because we know that our CPAP and BiPAP, they provide constant positive airway pressure, while in HFNC, it provides constant high flow with variable pressure. Yeah. However, they are in theory and technicality, both are forms of non-invasive respiratory support. So with regards to this talk, I would include HFNC along with NIV as non-invasive respiratory support. So let's move on to-do list number 1, which is do familiarize yourself with the basics of NIV. We know that NIV provides positive pressure to the airway, and it was proven to improve the status of your pulmonary edema and COPD. And HFNC, or high flow nasal cannula, on the other hand, provide constant flow with variable pressure, and it washes out the CO2, causing a reduction in the dead space. Yeah. More details on the basic of NIV. We know that our CPAP, continuous positive airway pressure, is basically we apply PEEP to prevent atelectasis, and it works by stenting open the alveoli. It also reduces shunting, and it decreases preload and myocardial demand as well. So you want to increase your PEEP, basically your EPAP, which is your PEEP, to improve hypoxia. Yeah? BiPAP, on the other hand, which is your bi-level positive airway pressure, is best used with chronic respiratory disease like in your COPD patient. So it might be useful in COVID-19 patient who have these comorbidities like COPD plus COVID-19. Yeah? And as the name implies, BiPAP, bi-level, it provides 2 different positive pressure, which is your IPAP, inspiratory, and your EPAP, expiratory positive airway pressure. And the difference between your IPAP and your EPAP is your driving pressure, the pressure support that drives the ventilation. So you want to make sure that you maintain this PS value throughout your settings. Yeah. And last but not the least, your high flow nasal cannula. Basically, this has been looked with the high regards since the Florali trial in hypoxemic respiratory failure, in which it was proven that HFNC is non-inferior as compared to NIV, with some ICU and 90-day mortality benefit. Basically, the high flow rates can reduce the dead space and decrease the work of breathing as well. And you can set 2 parameters, the flow rate and FiO2. And I think Dr. Chan have a topic on how to use your HFNC in COVID-19. Yeah. So again, know the basic concept of all this, your NIV, your HFNC, before starting using them. So let's move on to to-do list number 2. Choose the correct interface. All right, there has been ongoing debate on which interface should we choose when using an IV. And these are the 3 most common ones: your nasal mask, your face mask, and also your helmet. Yeah. So which one to choose from? So let's see at the evidences, and this is the systematic review of comparison between different interface of NIV delivery. And based on this, actually, there is no strong evidence that one type is necessarily better than the others in terms of clinical efficacy. So basically, if you see these studies, they are not homogeneous. We have different type of patients, different type of illness and population, and we really have to consider the heterogeneity of illness in acute respiratory failure. So it is hard to say which one is best for patient because our interface actually is mainly influenced by patients, your face shape, your nasal pathology, experience of the staff, patient's comfort and tolerance, and most importantly, equipment availability. So it is quite important to let the patient try different types of interface and choose the one that is most comfortable and efficient for them. Yeah. All right. So with regards to this, the optimal interface and ventilator design has not yet been determined, and these may differ among patients. Basically, there is no universally ideal NIV interface. Choosing, again, the interface requires a thorough evaluation of the features, ventilatory modes, and respiratory failure type. And this statement published in 1994 still rings true. So let's move on to the third in our to-do list, is do acknowledge the risk of transmission. All right, we know that everyone is afraid and scared, but we do really have to acknowledge the risk of transmission to come up with a strategy to combat the risk. We do know that the risk of transmission to ourselves depends on prolonged exposure, improper donning and doffing, and also insufficient spacing as well. And the risk is actually higher when patient was put on non-invasive ventilation or non-invasive respiratory devices. David S. et al. Has come up with many studies on air dispersion on different conditions like this one, your HFNC versus CPAP. And the way they did it is by using human patient simulator with a light sheet here positioned at the patient, and the jet plume were captured using high definition video cam, and they will be analyzed. And it is interesting to see the air dispersion distance between the different oxygen administration. Like in this one, we can see that your nasal cannula with 5 liters of flow has the maximum dispersion of approximately 1 meter as compared to your high flow mask, non-rebreathing, on less than 10 centimeter. And it is also very reassuring. Yeah, we can see that CPAP with oronasal mask and NIV with the helmet with a high setting, they have negligible air dispersion. This is very reassuring if they are used very correctly. And your HFNC, on the other hand, have only 17 maximum dispersion if fit correctly. Another interesting finding include this table in which we can note that the one with mask, yeah, your surgical or N95 carries the least distance of dispersion. So what are we getting by acknowledging this risk of transmission? So as I said, we can come up with a strategy to overcome the risk by several measures. So we have some general measures. For example, we want to put a patient on NIV in an isolation room with negative pressure, and this is the ideal setting. But we do know in our heart that this is not really possible, but it is okay. We can cohort them in one area with 1 meter distance with good airflow, and that is okay. And of course, we have to wear full PPE. It should be worn, no question, and we should reduce AGP procedures in these patients. Yeah. And specific to NIV, we should wear them surgical mask on top of the NIV and HFNC. And very important, we have to ensure that placement of the nasal cannula is inserted in the nostril properly and it is secured. Yeah. Number 3, with regards to NIV support, if possible, use a double limb circuit with a non-vented mask. And with regards to filters, number 4, you can actually put at least 3 filters between your expiratory and inspiratory port and your ventilator and near the patient mask. All right, one more interesting concept is by putting surgical mask on top of your HFNC or any oxygen devices, as I stated before. And it's like this, killing 2 birds with a stone. Not only from this study, it prevents the dispersion, it also offers an advantage in terms of oxygenation in COVID-19 patients. So the summary of this risk of transmission with NIV in COVID-19, we do acknowledge it carries risk of dispersion. However, it allows us to actually properly set the patients and device up. And worry not, because evidence suggested that proper PPE are effective in preventing infection among us. And in one report, none of the HCW contracted the disease if there is strict adherence to proper PPE and SOP. Fourth on the to-do list is do consider awake proning. Dr. Azli has talked about this, but I would like to re-emphasize about this because it is very, very interesting. So I will just go superficially. Yeah. All right. So I think this is probably the first article to recognize the value of awake proning in COVID-19. Yeah. So basically, these authors describe a treatment strategy employed in their center. And in this flow, you can see that they include in awake proning, and this method was found to correlate with lower intubation and mortality. Yeah? So let's see at the evidences of awake proning in COVID-19. These are some of the findings or studies or result of some case series which revealed to be successful. While we know that large RCTs and robust data are still lacking, awake self-proning have been shown to improve oxygenation in COVID-19 in multiple observational studies. Yeah, and we also know it is zero cost, no cost at all. It has very minimal complication. So why not consider this? Yeah. So the effect on mortality of awake proning are yet to be studied in controlled trial, but we are very looking forward to ongoing studies like your ProCov, OptiProne, and approved COVID-prone. So I think stay tuned. I would like to re-emphasize again about this. Yeah, this is the schematic representation of the lung: A supine, B prone. This is your heart. This is your alveolar, the circles, and this is your blood vessels. So basically, you can see in supine position, the posterior alveolar is collapsed and there is overdistension of the ventral alveolar. Yeah, so the perfusion is more posteriorly. So there is V2 mismatch. So when you put in prone position, the recruitment of the dorsal alveolar improved, and this will of course improve the VQ ratio. So as Dr. Aziz said, there is no reason that we cannot put the patient on awake proning if you are using NIV. Like this one is using HealthMed CPAP, this one is using high flow nasal cannula, and they were able to prone themselves down. This is the proposed algorithm of awake proning, in which basically if patient is not saturating too well with tachypnea, but still alert, obeying command, and can monitor and prone themselves down, they are the candidates for awake proning. So some question and answers on awake proning. Whom can we awake proning? Of course, not a candidate of invasive mechanical ventilator. That one is different. Yeah, but patient should be alert, conscious, cooperative, obeying command. Yeah, and question number 2, how to do. I think Dr. Azli again has said this in very detail, explain the procedure, emphasize to them that maintain the position at least 30 minutes to 2 hours, and you can alternate between proning, semi-proning, and lateral position as well. The contraindication of awake proning, this is like the same contraindication for NIV itself. In patient who is in need of intubation, who has compromised airway, who are unstable hemodynamically, they are not a suitable candidate for awake proning. Question number 4 would be, what is the care during awake proning? So basically, most important is continuous vital sign monitoring. So look at the patient, the SpO2, respiratory rate, the vital signs, and you have to do it continuously and repeatedly. And if possible, put a call bell, and the patient can call you up when available. Last question would be, how long do we awake prone the patient? So the optimal duration of awake proning has not yet been studied, but it is advisable to be maintained at least 30 minutes to 120 minutes, and it is advisable to do frequent proning to an average of 5 to 6 hours per day. All right, last but not the least in our to-do list, but I think the most important of all, do implement strict monitoring to your patient, because putting your patient on your NIV without monitoring is like riding a race car without a driver, which is very reckless, dangerous, and irresponsible as well. So do implement strict monitoring to your patient. We have a specific topic by Dr. Azma on monitoring of your patient, but I will touch superficially on this just to give you a rough idea on what monitoring you should do. So most important is always your clinical monitoring. Approach the patient, look at them as a whole. Yeah? And of course, you want to see the gas exchange, the cardiac and respiratory system function. And also you can use your tool, your Hako and ROX score as well. As I said, most important is your clinical condition. Everyone should do this. Yeah? Look at your patient, look at the comfort and tolerance, look at the work of breathing and respiratory rate, look at the vital sign as well. Yeah? And this is very important to anticipate early deterioration of your patient. Yeah. So again, please monitor the clinical condition of your patient. So next is monitoring the gas exchange. And of course, you want to look at your SpO2, your ABG, your PaO2, and your PaCO2, and try to maintain them within the target range. And next is your cardiac function monitoring, which is very important because we are actually applying PEEP, positive pressure. So basically, the LV preload and afterload will decrease, and application of your PEEP will reduce your cardiac output. Yeah. So how to monitor the cardiac function? So again, as I said, most important is always your clinical. Yeah. So look at the clinical condition of the patient, look at the perfusion pulse volume, look at the vital sign, the BP and the heart rate, the mentation, yeah, do one ECG if need arises, and you can adapt your POCUS point of care ultrasound to look at the systolic and diastolic function as well. This first video showed a very poor LV and RV systolic function. And this one, the second video, showed a globally hypokinetic heart with a very poor LV ejection fraction. And you can just imagine how bad the hemodynamic status and lung status in this patient. You can also look at the diastology, look at the EA ratio, and do some TDI to look at the EE ratio. And basically, with these information collectively, it can guide you through the treatment. For example, patient with a bad systolic and diastolic function, they are not a suitable candidate to be weaned off your NIV, and maybe you need to administer some vasodilators and diuretics to combat the problems. You want to also monitor your respiratory system by, again, clinically, go to your patient, look at the work of breathing, the respiratory rate, the SpO2, the vital signs. This is again to anticipate any clinical deterioration. And of course, you can end up with your POCUS to look at three main things: your alveolar, which is your lung aeration, your pleura, and your diaphragm function as well. So this is how to do scoring to monitor the global function. Although it is meant for ventilated patient, extreme situation calls for extreme measures, and this one can be adapted into our NIV patient. Yeah. So basically, you divide your thorax into 2 hemithoraces, 6 regions on each side. So basically 12 regions, and you score each region, 0 point for A lines, 1 point for well-separated B lines, 2 points for coalescent B line, and 3 points for consolidation. So you have maximum of 12 regions, and 3 scores, 3 times 12 is 36. Maximum is 36. So this is very helpful because you can do it at 0 hours and later after 1 to 2 hours after commencement of your NIV. And if the score, for example, goes down from 30 to 10, then you are happy, you're on the right track. But if it doesn't, then you should really consider to step up in your game. All right, this is monitoring of your pleura, for example, like this one, massive pleural effusion, and this indicates that this patient cannot be weaned off your ventilator until you drain the fluids out. Yeah. And of course, you can always monitor the diaphragm function. You can look at the excursion, how it moves during respiration, and you can also do the fraction thickening of the diaphragm. And this is how you do it, just superficially. Put your probe like this, and then you, like TAPSE, you put a mode and measure the distance, the excursion between inspiration and expiration. Yeah. For the thickening fraction, you can put your probe at the zone of apposition, and you see the thickness different between inspiration and expiration, that you can have a rough idea on how the diaphragm is functioning. Last but not the least, you can use this monitoring tool. I won't touch in detail. You can use your ROC score or HACO scoring. Although this is very famous and developed for non-COVID patient, it has actually been adapted to COVID-19 patient, and it can predict the outcome of your patient, which HFNC or NIV. So I think that's all the to-do list that I think crucial in our NIV management in emergency department. For the big don't, I have again only one big don't, which is do not delay intubation in patient who needs immediate intubation. That's the big don't from me. So I have only one take-home message. Yeah, in the wrong hands, all tools are weapons, and in the right hands, everything is a weapon or nothing is. So again, know the basics of your NIV, choose a proper interface, acknowledge the risk of transmission, consider awake proning, and monitor your patient with NIV. And of course, again, do not use your NIV as a bridge to delay intubation in patients who are in need of immediate intubation. So I think that's all. These are my references. And for the next talk, I would like to invite Dr. Chan Pei Fong, emergency physician from Hospital Raja Permaisuri Bainun, to give her talk on high flow nasal cannula in COVID-19. So, all right, Dr. Chan, I'll pass the screen to you.
Good morning, all. I'll be talking about HFNC in COVID-19. This is the content of my presentation. I will tell about what is HFNC and the mechanism of action. I will summarize the evidence of use in ED and COVID-19 and also talk about its disadvantages. And I will discuss when to start HFNC and how to set it up in your ED. Let us look at the spectrum of oxygen and ventilatory support that can be provided to someone with acute respiratory failure. The conventional oxygen therapy is devices that provide oxygen flow below 15 liters per minute, which we consider as low flow. This can be when oxygen goes above 15 liters, is given to the patient, it can be very uncomfortable. And this can be provided via this new device, what we call a high flow nasal cannula, which provides heated and humidified gas. The flow can go up very high, up to even 80 liters per minute. Notice that the initial discussion is all about providing oxygenation that supports mild respiratory failure. And this patient can breathe and they can blow out their own CO2. As the patient became more hypoxic and they will become tired and they may have CO2 retention, that is when they step over and they need a ventilatory support. This can be provided by what we call a non-invasive ventilation, which there could be some overlap in the terms, but some people prefer to use the word non-invasive positive pressure ventilation. So when we are providing ventilatory support, we actually move over to give a bit of positive pressure ventilation. But if the patient is drowsy and cannot protect his or her airway, then we will need a definite...
Dr. Chan,
Yeah.
Sorry to interrupt you.
Yes.
We cannot see your screen. Can you reshare your screen, please?
Okay, sorry. Sorry, there's some technical error. Maybe because I
right, we
share
can
the
see now.
PowerPoint. Wait, I think I share again. I'm sharing screen. Can you see it now?
Yes, you can put it on the slideshow.
Did you all hear the earlier part of the talk, or do I need to start again?
Yes, you can restart again, I think.
Sorry for the technical problem. I'll be talking about high flow nasal cannula in COVID-19. This is the content of my presentation. I will be telling you about what is high flow nasal cannula and the mechanism of action. I will summarize the evidence for use in ED and COVID-19. And I will discuss when to start high flow nasal cannula in the COVID-19 and how to set it up. Let us look at the spectrum of oxygen and ventilatory support that can be used for someone with acute respiratory failure. The conventional oxygen therapy uses a low flow oxygen therapy, which is oxygen below 15 liters per minute. But when the flow goes above 15 liters, we need the patient become very uncomfortable. So they need a special device, what we call a high flow nasal cannula, which provides a heated and humidified gas to the patient. Notice that the initial discussion talks about oxygenation support to mild respiratory failure. And the patient can still breathe well and blow out his own CO2. As the patient becomes more tired due to worsening respiratory failure, he may have CO2 retention and he needs some ventilatory support. This can be provided by NIV, which gives positive pressure ventilation. Some people tend to confuse the use of terms. So for the sake of this lecture, I will use those NIPPV, we use non-invasive positive pressure ventilation to signify those patients on helmet, CPAP, BiPAP, and face mask, while we will use high flow nasal HFNSC to signify those patients on the high flow gas. High flow nasal cannula differs from NIV that it provides less ventilatory support. You set the flow rate instead of setting inspiratory and expiratory pressure. Therefore, the pressure provided by high flow nasal cannula is much lower in comparison to compared to NIV. That's a request for me to on my video, so just hang on for a moment. Right. The humidified high flow nasal cannula is provided via a single limb inspiratory circuit to the patient through a very large diameter nasal cannula. We usually start the flow at the lower flow, around 20 to 30 liters, to allow the patient to accustom to the high gas flow. The rate can then be titrated up to max 70 to 80 liters, depending on the new machine that you're using. An air oxygen blender is connected to provide oxygen between 100%, 21 to 100%, which we usually actually start at a higher FL2, and then you can decrease it down until you get the saturation that you target. The temperature of gas also can be set. Usually we start at your body temperature, and we can actually decrease it down according to the patient's comfortability. The mechanisms of high flow nasal cannula is nicely summarized by Vibel at EM using this mnemonic high flow. Heated and humidified, as the name implies, provides a comfortable gas to the patient. And is inspiratory demand. The flow rate in conventional oxygen therapy is actually very variable. This is because when the patient is in a respiratory distress, the inspiratory flow rate is very high, and this oxygen can be diluted when it's mixed with room air. So this HFNC ensures continuous flow and actually can meet the peak inspiratory flow demand of the patient. So the oxygen level that's provided is more this one more reliable and high FL2. The FRC functional residual capacity is increased, and this will lead to a delivery of a small amount of PEEP, and L implies lighter, so patient, this is a more tolerable interface compared to the NIPPV interface. Because of the high flow of oxygen, it washes out the dead space in the airway, and so this it washes out the pharyngeal dead space and allows CO2 removal. As mentioned, HFNC provides some level of PEEP which usually about 1 centimeter water per 10 liter per minute of flow rate. That means if you give the patient 30 liter per minute, you will get about PEEP of 3. And if you give 50 liter per minute, an estimate PEEP of 5. However, be careful that this is only true if you have a nice fitting cannula and the patient do not open his mouth to keep talking. When he opens his mouth, the PEEP level will drop. HFNC has been used for some time in ED for 4 main indications, which is the acute hypoxemic respiratory failure, hypercapnic respiratory failure, as a pre-oxygenation tool before intubation, and as prophylaxis after extubation. I will go through very quickly the evidence behind the use of each indication. So a Florali trial is the landmark trial that popularized the use of HFNC in acute hypoxemia. In this prospective, multi-centered, randomized controlled trial of 310 non-hypercapnic hypoxemic patients, HFNC was found to be non-inferior to standard oxygen therapy and NIV. In fact, in a subgroup analysis of patients with moderate hypoxemia, HFNC was associated with reduced incidence of intubation. And the probability of survival after 90 days was also higher in HFNC compared to the other 2 groups. So HFNC reduced intubation and improved mortality compared to NIV in acute hypoxemic respiratory failure. Of NIV in the form of IPAC is very strong in chronic respiratory failure. The meta-analysis of this meta-analysis by Huang et al. On 6 RCTs and 2 cohort study found that actually HFNC is non-inferior to the NIPPV in mild to moderate hypercapnia, which means if you ran out of your BiPAP or mask and the helmet, you can actually use HFNC as a safe alternative to, for patients with mild to moderate hypercapnia. The use of HFNC as a pre-oxygenation tool has been popularized by this study called THRIVE study, which this Patel in 2013 found that HFNC, if used before and during intubation, can actually increase the apnea time to about 14 minutes and keep those patients who are being intubated at the level of above 90%. There were found to be no desaturation during the intubation. And this Florali 2 trial also found that when HFNC is compared to NIV, there was no difference between these 2 tools. And it both also does not cause severe hypoxemia during intubation. So you can safely use both HFNC or NIV as a pre-oxygenation tool to prolong your apnea time in the A&E. What about post-extubation? The Dr. Fernandez and team published few large RCTs on HFNC in post-extubation from 2016 to 2017. The authors concluded that HFNC is actually a very powerful respiratory tool for post-extubation period and is non-inferior to NIV. A recent RCT called the HIVIN trial, conducted on 600 plus patients, found that for patients with high risk of extubation failure, the use of HFNC combined with NIV actually prevent reintubation in this group of patients. So this NIV is commenced immediately after extubation and is given for about minimum of 12 hours. And in between, you put on the high flow nasal cannula so that the patient can become more comfortable. What about the use of HFNC in COVID-19, which is the main part of the talk today? In the early days of pandemic, early intubation when oxygen requirement is more than 6 liters was the strategy used. However, the mortality rate of those intubated is said to be 50% worldwide. And the prolonged course of the disease led to ventilator shortage. I'm sure most of your emergency department is facing this problem now. The problem of having a ventilator shortage because of the prolonged course of the disease. Therefore, how do we use HFNC? This led to the emergent use of non-invasive intervention in COVID-19. So a retrospective cohort study by Jaral, published recently at the ED, found that the early initiation of HFNC was able to reduce the rate of intubation by half. And the awake proning positioning is a good strategy to use in combination with HFNC or NIV. Which is preferred, HFNC or NIV, NIPPV? Duan et al. Compared the use of high-flow nasal cannula and NIPPV in critically ill patients in COVID-19 as a first-line therapy. The duration of intubation, the rate of mortality did not differ between these two groups. And no medical staff got nosocomial infection from the use of NIV. Another trial, the Hannibal trial, compared the use of helmet, BiPAP, and HFNC in COVID-19, and also found that there is no significant difference in the clinical outcome. Therefore, my take-home is there's no difference whether you use HFNC or NIV in COVID-19. But most literatures and international societies in the world recommend high-flow nasal cannula as the first line compared to NIV. This is because the higher risk of aerosol dispersion in NIV, and HFNC is better tolerated and facilitated the strategy of awake proning. But WHO warned that HFNC should only be used in selected patients, and these patients should be monitored carefully for clinical deterioration. I will tell you why in a while. Should you start NIV early? Should you start HFNC early? A retrospective study by Laura et al., published early this year, found that early use of HFNC was associated with the decreased need for intubation, mortality, and overall hospital stay. The early intubation in the study was defined as severe distress, patient without severe distress when the SF ratio is more than 100. Therefore, based on the conclusion of the study, the authors suggest that we start the HFNC when the patient has an SF ratio as less than 300, or when the FiO2 is about 40%. When you are using a ventilator mask, needing 6 to 8 liter flow. In that early stage, you should actually start the high-flow nasal cannula, and actually it can improve the clinical outcome. However, we may not be able to do so when the resources are limited in your A&E. So I'll talk about the disadvantages of HFNC, which there are two. The two main concerns are, the first, there's a risk of aerosol dispersion. Contrary to popular belief, a well-fitted high-flow nasal cannula has actually a very low risk of aerosol dispersion in comparison to NIPPV, the BiPAP face mask that you use, which has the highest dispersion rate of about 1 meter, and which is just next to the nebulization. So what can we do to overcome this problem? So there's this study that found that if you were to put on a face mask for a patient on high-flow nasal cannula, you can actually trap 70 to 80% of the aerosol at the face mask. And this is our solution. We put on a face mask for anybody who's on a high-flow nasal cannula. The second concern is HFNC may delay intubation and lead to increase in mortality. This has been known since 2015 that if you were to put patient on a high-flow nasal cannula, the apparent improvement may mask the severity and increase the risk of respiratory arrest when you intubate the patient later. So this another study by me investigated whether the time of failure make a significant outcome. It was found that if the patient is intubated 6 hours later after the HFNC, then there is actually an increase in ICU mortality. So if you start the patient on HFNC, please monitor the initial period very closely, because if the patient is to fail later, there is an increase in mortality. So when do we start the high-flow nasal cannula in a patient with COVID-19? I'm going to illustrate the next part of my lecture on monitoring of patient using a case scenario. A 40-year-old man came with a shortness of breath for 2 days, and these are the vital signs. So he is diagnosed with COVID-19 pneumonia, category 4, and he's on a high flow mass 15 liters per minute. His saturation is 80%. So the question I want to pose to you after listening to the long first part of the lecture is that, are you going to use HFNC or will you intubate the patient? So you have the question, your answer in your mind. Let's look through what is the suggested, proposed by the international societies. So this article by Rauf et al. Proposed this algorithm that we should base the oxygen supplementation on the severity of the respiratory failure in COVID-19 using a stepwise approach. As mentioned earlier, there are two main types of COVID-19, the L type and the high H type. The L type accounts for 70% of these patients, and this patient is due to a low elastance and high compliance. So the reason for the hypoxemia is probably due to the loss of perfusion regulation and hypoxic vasoconstriction. So these are the L type are the kind of patient that needs oxygen and not intubation. So these are the best type of patient for HFNC. In comparison to the H type, which has a high elastance and low compliance, those patients mimic ARDS. That forms 30% of the patients. But the problem is, how do we identify those patients based on the initial presentation? We are at ED level. The blood results might not be out yet. So this study might not be so relevant to us because it says that we have to base it on the PF ratio of if a very severe PF ratio less than 150, we should proceed with invasive ventilation. This is a proposed algorithm according to the severity based on ABG. So another recommendation is by the Society of Critical Care of Medicine that suggests we select the patients by looking at the extreme end of the severity and consider the need for intubation first. Then only we think whether the patient can use other modes of therapy. So what does it mean? It means that we ask ourselves, is there an immediate need for intubation? If there's an obvious sign for intubation, such as refractory hypoxemia, the patient is drowsy and due to hypercapnic encephalopathy, the patient is very exhausted, in fatigue, and you know that this is a pre-terminal event, then we should proceed straight to intubation. We should not wait for the blood results as proposed by the earlier algorithm. There are two schools of thoughts in regards to when is the right time to intubate in COVID-19. The first group of clinicians prefer to intubate early and take over the ventilation with sedation and paralysis. The second group will allow the patient to go to the very far end until the respiratory failure fatigue is detected, until respiratory fatigue is detected before intubating. So which group are you? The decision to intubate, I always tell my MOs, should be based on the benefit versus the risk ratio. So if you were to see what is the risk, let me summarize. The risk of using high-flow nasal cannula or NIV is there is an aerosol dispersion, which won't be a problem if you are on full PP in the respi zone. It can delay intubation and increase mortality. So if your aid is very busy with 10 intubated COVID patients down there, so maybe NIV is not suggested if you don't have enough staff for monitoring. And apart from that, there's also another concern that the patient can have a self-inflicted lung injury, we call PCD, in patient with spontaneous breathing due to damaged lung and high respiratory drive. This high volume of tidal volume can actually aggravate the initial lung injury. So that's why the first group of clinicians prefer to intubate and take over the ventilation by paralysis. Okay. What is the benefit of putting on an NIV or HFNC? Is the patient is easy to manage and they can do their own self-positioning like prone. You maintain the spontaneous breathing, so you can avoid those the nursing care such as giving suctioning or feeding. And also you can actually avoid the intubation-related complications such as asynchrony or HAP, ventilator-acquired pneumonia. So what is the best strategy for these COVID-19 patients? To me, it is still to weigh the benefit and risk depending on your resources and availability of staff. Going back to our case, the patient is a typical presentation of a happy hypoxic patient because he's still alert and his vital sign is relatively stable and his saturation is low on a non-rebreather. So I am putting my guess that he is a L type of COVID-19, L phenotype. So I decided to give him a trial of NIV. Now, which one should you choose? Do you choose the high flow nasal cannula, the NIV, NI positive pressure ventilation BiPAP CPAP, either helmet or face mask interface, or do you have both, none of that? So you can actually choose either one, and as we discussed so many times today, there is actually no difference. But if very unfortunately you are in a district hospital or you ran out of these two devices, then there is a third option of putting this what you call a modified CPAP, a non-rebreathable with a high flow the nasal cannula. But bear in mind the nasal cannula don't go above 5 liters because it's very uncomfortable for the nostril and it will dry it up. So at the moment, there's no evidence for this device, but it is the best you can do for the patient in a district where you have no resources. 1 hour later, after putting on a high flow nasal cannula, the patient is more comfortable. But you see on the monitor, he's still hypoxic and he's hovering around 80 to 90%. So what other methods can you improve the oxygenation? If you do not already know the answer, then you must have been sleeping the whole day. So the answer is you can actually reposition the patient. I won't talk further about this since we mentioned like the countless time already. So now I will go through the steps to set up a high flow nasal cannula from a Hamilton circuit. It's for the benefit of the MOs in my department. Bear in mind that your department may use other devices and there could be some differences between the machine, but the principles should still be the same. So the step 1 is to fill up the water compartment. Usually we actually should put a continuous drip bottle as in a continuous device to ensure the water doesn't go doesn't dry up. But unfortunately, for this video, the device was missing, so we had to use manual. So you fill up the water until the maximum level as suggested by the machine. That's the first step. The second step is, of course, connect the tubing.
Then from patient to ventilator here. From ventilator to patient here. Then this one from patient to ventilator here.
Don't worry too much about it. Actually, there is a small picture at the tubing. And you can actually just follow the color as shown by the device. The third step is to set up the ventilator and the mode, the setting.
And it's just high flow oxygen confirm. And it's just the flow recently is quite low, around 40. And oxygen is at 60. And you confirm. Then you start therapy like a baby. What's the more?
And the last step is to attach the high flow nasal cannula to the patient. This I got the permission from the patient. So you must choose not the high cannula that fits the nostril properly. If not, the machine will give a alarm of a change interface or check interface. So my take-home messages, HFNC provides good oxygenation support and minimal or some ventilatory support to the patient. The use of HFMC combined with awake proning can decrease the rate of intubation in COVID-19 patients. But bear in mind that we need to be aware of the two main disadvantages, which is the risk of aerosolization and that it may delay intubation. So close monitoring is needed repetitively and is recommended to look for HFNC failure. With that, I thank you and I end my lecture. So now we are going to have a 10 minutes break. And after that, we will have our very distinguished speaker, which is Dr. Adi Osman. He's a consultant emergency physician at the HRPB Ipoh. He'll be talking about the helmet in the COVID-19. So stay tuned and we will come back at around 11:05. Thank you very much.
Assalamualaikum and very good morning. Okay. Welcome to our first NIV course for emergency medicine. So I think I would like to share this picture. This is actually a picture taken from Hospital Raja Permaisuri, the Bainun, during pre-COVID era. You can see how happy even the hospital itself, and it's quite happening. Right? Things have changed a lot since 1.5 years ago during COVID era, and we don't see much of this kind of environment with all the tent is actually almost covering the whole hospital. Right. So my name is Ali Osman. I'm from this hospital, Raja Permaisuri Bainun, Trauma Emergency Department. Right. So I can move my slide. All right. So this is the most important slide. So in summary, I purposely put this summary into the second slide because I think this is probably the most important slide. And if you look back into this summary, what I'm going to talk in this probably half an hour, I will talk the advantage of this helmet NIV, especially for COVID-19. And one of the advantages actually is transparent, right? It costs less in terms of claustrophobic. It's lack of facial contact. Okay, sorry. Most of the time, we don't need to sedate patients, right? And the main advantage of this helmet CPAP is able to deliver higher PIP, right? And it better tolerated for a long period of time. And of course, in this COVID era, the most important thing, it costs less in terms of aerosolization and also exposure to our healthcare workers. And of course, there's a lot of shortage in terms of ventilator. Even our high flow nasal cannula, we have a lot of problem in terms of shortage. So helmet, it probably is one of the alternative NIV in this COVID-19. Right. So this is actually a systematic review and meta-analysis published by Liu et al. In Critical Care 2016. What they found is actually the advantage of helmet. It reduced the hospital mortality and reduced intubation rate. And of course, it less in terms of complication and reduce in terms of length of ICU stay. So I remember when I first started bringing in helmet CPAP in 2010 after my fellowship in Italy, a lot of people kind of think it's kind of weird when they start saying those people with plastic hood being wrapped around the neck, the head, and most people think that it's almost resemble this picture, right? But it's true. This is actually it's almost look the same in terms of appearance, and of course I can assure you, okay, post helmet CPAP, this is how a patient will look like, and I will talk more on this. Right. So the basic fundamental of physiological problem in patient with acute respiratory distress that needed NIV in our ED emergency department is reduced in FRC, the functional residual capacity, right? And because of this, it causing a lot of atelectasis and lung collapse. And what is actually the result of this pathology? That we will reduce in pulmonary compliance with increase in airway resistance, and worse, it causes increase in work breathing, and of course, it causes a VQ mismatch. So, by opening this collapse or unventilated alveolar, what we get is actually there will be improvement in FRC that we in turn reduce the intrapulmonary shunting, okay, and opening the under ventilated alveolar, and at last it improves the oxygenation. This is actually the basic principle of NIV. Any NIV, this is the basic principle. So the other function of NIV is actually to kind of offset this autopip, whereby we know that autopip will actually what call air trapping, because increase the work of breathing is actually causing a lot of dysynchrony in terms of trigger, and of course it causes hemodynamic instability. And by offsetting this autopip, they improve all this. Okay, improve the work of breathing, and of course improve in terms of triggering, and improve in terms of hemodynamic. This sometimes we call it waterfall effect, but it's only true. Okay, I repeat, it's only true in a flow limited in the tidal ventilation. Right? So this is actually the meta-analysis randomized control trial looking at actually the benefit of this kind of NIV. So what I'm trying to share here, total overall benefit is actually it reduced the hospital mortality. So Dr. Faiz have discussed about this. This is my version of what I normally do. This is my 5 do and 5 don'ts in what I call it NIV. This is very important principle before we decide on any NIV in any patient. And most of this will be actually be discussed by previous lecturer and the next lecture during this workshop. The first principle is actually you need to select your patient wisely, right? This is actually a study published by Navalasi. It's an old study published in 2004 intensive care medicine. What they found is actually 37%, okay, almost 1/3 of patients. The reason for NIV failure is patient cannot tolerate your NIV. Of course, another probably 1/3 of cases is due to worsening of ABG, right? Patient become more acidosis, increase worsen in terms of respiratory acidosis, okay, etc. So, how to choose patient wisely? This is actually a study published by Antonelli. I think most of us know who's Antonelli. He's actually the world authority in non-invasive ventilation, especially on helmet CPAP, helmet ventilation, okay, NIV. They did a multi-center study looking at predictor for failure on NIV. What they found is actually very important. Okay, don't use NIV patient with high severity score. Okay, SAPS. Okay, more than 34 SPI2. Okay, elderly patient because of the reserve in terms of physiological reserve, respiratory reserve, cardiac reserve, and some of these patients they tend to get a respiratory fatigue. So you need to be careful. Okay, those with severe metabolic acidosis. Those with severe hypoxia, okay, PF ratio is less than 150. In COVID, the magic number that we normally use is actually 200. So patient presented with PF ratio 200, COVID-19, you need to be careful, right? And of course, the most important thing in emergency department is failure in improvement of PF ratio after 1 hour treatment. So if somebody asks me, when do I review patient? In emergency department, after I start patient NIV, the magic number is 1 hour, right? So the second thing that you need to do before decided on what is the best, how to start, whether this patient is actually a good candidate for NIV, to estimate the risk of failure. I think one of our speaker will discuss more on this after this lecture. So I use this. Okay, we use this hardcore score, okay, since probably 3-4 years ago. I personally found this actually is quite relevant in terms of predicting which patient we're going to have NIV failure. It's a simple score. Sorry. Okay. It's a simple score whereby HACOR, meaning H stands for heart rate. HAA is actually the acidosis, okay, pH. C is actually the conscious level, okay. O is the oxygen, which is the PF ratio, and R is actually respiratory rate. Okay. Any patient presented to us with HACO score than 5, okay. If you look into this statistic, the risk of NIV failure based on this study published by Duana et al., okay, intensive care in 2017, the risk of NIV failure is almost 75%. Meaning almost 2/3 of your patient will having NIV failure, okay, NIV failure if they presented to you with HACO score is more than 5. And of course, it's very important for us to actually to review patient after 1 hour after you start patient on NIV, right? And this is actually the gist of my presentation. Pick the right interface. Okay, interface mean is actually how you're going to deliver your NIV. Right? What we actually use now? I think if you look, this is old data published by Nava in European Respiratory Journal in 2010. They found it's actually 60% of the most commonest interface used in Europe is actually the face mask. But I didn't come across the data, statistic data and usage of the interface. But I was told that recently this helmet CPAP is actually approved by FDA to use in US. Okay, and there's a lot of usage now. In fact, in Europe, for example, in Italy, the most commonest use NIV in terms of interface for COVID-19 is actually helmet CPAP. Right? So, what is the most ideal interface? Okay, if we have a choice, what is your ideal interface? They be well tolerated. Okay, no leak, minimal in terms of dead space, and almost no zero carbon dioxide rebreathing. Patient can speak, can swallow, and of course adapted to patient anatomy. So for the time being, we don't have this kind of idealistic. Okay, we don't have ideal interface. Okay, the one that almost resemble this idealistic parameters is actually helmet CPAP and probably high flow nasal cannula, right? And we all know that nasal CPAP is actually well tolerated, right? It costs minimal in terms of dead space. It's easy, quite easy. Okay, patient can speak, but you can't put it in talkative patient. Okay, the moment patient open up their mouth, okay, you're losing the PEEP effect, right? Face mask is good. It's a fact in terms of stability. The problem is that you see, okay, if you put patient on this face mask in longer period of time, you start seeing the pressure sore, okay, and of course it's causing a lot of tolerance issue, and some people that they cause a lot of claustrophobia. Sorry. Full face mask similar, right? You have problem with what I call it dead space, right? And this is actually a study published by Meta in 2001, published in a Blue Journal. What they found is actually the problem with this face mask. Almost all patients have problem with a leak. Of course, the discomfort and all the ulceration of this skin erythema, etc. Right? So this is helmet CPAP. Okay, there is the advantage and disadvantage. As I mentioned earlier, we don't have a perfect or the most ideal call it interface. Most of the time is suitable for most pathology, respiratory pathology. But of course, as I mentioned, I will discuss more on this. It causes a lot of asynchrony. Okay, if we don't set it properly, in some time it causes in terms of claustrophobia. Okay. Okay. Today, the use of helmet CPAP is not something new. If you Google, okay, today probably you come across at least 160 studies. This is what talking about the physiological studies and clinical studies looking at it. We have a technical paper and bench study looking at the safety, looking at CO2 removal, looking at the dead space, looking at the performance, what is the appropriate setting, how to avoid synchrony, desynchrony, how to reduce the noise, how to make it more comfortable and a kind of nursing. Okay, and when we talk about clinical papers about the specific pathologies, okay, there's hundreds of evidence looking at the, for example, in acute pulmonary edema, in COPD, okay, in RDS, etc. Right. So this is the most important. Okay, the technical part of it. This lecture is aiming for those who never use helmet CPAP and those who actually beginners in helmet CPAP, right? I know some of you have been using helmet CPAP for quite some time, okay? You might need to know the advanced use of this, okay? You can PM me personally, okay? So my aim for this talk is actually for those who never use and those beginner. Okay, this is a setup one, okay? I personally think this is actually the most simpler setup, right? For those who want to start using helmet CPAP. I repeat, this is the most simpler for those who want to start and those who never use helmet CPAP. Okay, we're going into the physiology and physics of it. What do you need? If you look at helmet CPAP, it's just a hood, a transparent hood, which is a plastic. Okay, you have in and out, right? What is in is actually fresh gases. Okay, fresh gases. Okay, how you get these fresh gases is either by mixing oxygen and air, compressed air. Okay, once it goes, this is actually our flow meter, the cheapest version of a flow meter. Okay, and you have a more high-end kind of a flow meter, which is probably 10-20 times of this, right? So this is oxygen, this is air. Okay, you mix together in this oxygen air blender, and there is before it's going out, there is a venturi effect here. Okay, it increased the airflow to almost 40 to 60 liter per minute. I repeat. Okay, why do you need more than 40 liter? Right, because you must remember, in order to inflate this helmet, you need this kind of fresh what I call air that rushing through into this helmet, right? And of course, we're going back into basic physics. Okay, resistant to flow, we create a pressure. Okay, so what happened? Okay, because of before it's going out from this helmet, okay, there is a resistance to flow. You can actually dial this, okay, to actually to get the appropriate or desired PIP that you want. Okay, so some of it will leak. Okay, but you can control this valve to actually to create how much ambient pressure that you actually want in this helmet. So what you get is adjustment of this ambient pressure inside helmet is actually the PIP effect, right? So it's quite simple. Fresh gas in is create the pressure. Okay, how much pressure inside this helmet is actually determined in how you actually dial the valve, and you can see the PIP going up and down. That is determine the ambient pressure inside this helmet. The other important structure that you must be careful, there will be fitting. Okay, it must fit nicely. Okay, over here, and less, they will cost less in terms of air leak, right? So I repeat, this is the best, simplest to understand setup, right? But there's another simple setup. Okay, if you don't have budget in terms of buying this flow meter, expensive flow meter, it's actually directly using oxygen 15 liter and 15 liter of oxygen, double. Okay, and this, okay, this is actually the venturi kit. Similar, it causes a venturi effect, and it rush the fresh gas into this helmet and generate almost similar in terms of airflow, with almost more than 40 liter per minute. And in order to get what is the appropriate FiO2 and the PIP, this is actually the A, the B. Okay, you can actually titrate it. Okay, depend how much PIP you desire and how much FiO2 you desired FiO2 and desired what I call it, the PIP, right? There's another what I call it, oxygen blender or flow meter that available in the market. The other side is 50, the other side is 30 liter per minute. It depends, right? So the other setup, this is more complicated. It's more complicated than the first two that I mentioned earlier. So my advice is actually, if you want to use this setup, okay, you must be familiar with the first setup that I mentioned earlier. Because, and the other thing is actually, this is not called helmet CPAP, because what happens is actually, you're using your dial two things. You dial the PIP or CPAP plus the pressure support. Okay, if we want to use this setup, that's why I changed from helmet CPAP, the terminology, into helmet NIV. Okay, it's quite simple. Similar to any mechanical ventilation, you have two limbs. You have inspiratory and expiratory. Okay, inspiratory and expiratory. And the other setup, I'm going to discuss more on that setup. The other setup, which is quite interesting, we recently actually been called by Dr. Teo Ai Hao, one of our consultants, senior consultant, IFI from Penang, whereby it's quite interesting because now we're having problem in terms of oxygen. Okay, in terms of oxygen, they come up with a very innovative idea using the industrial compressed air. It's a 50-liter tank, which enough to generate a few we call it compressed air, using all this gadget. Okay, so what this is actually unpublished physiological study that based on our recent findings. What we found is actually, if you just want a FiO2 of 0.2, using this compressed air without using oxygen, you can actually generate at least PIP. But somebody, one might say, okay, patient that need NIV, they need high PIP and high FiO2, right? So it makes sense. So, and based on this unpublished physiological study that done by Dr. Teo and team, using the oxygen flow rate of 10 liter per minute, okay, plus the compressed air, okay, which is somewhere around 15 liter per minute, okay, you can get PIP of 5 and you can achieve the FiO2 is 0.6. So what make this thing interesting, this innovation interesting for me, okay, is actually you can save a lot of oxygen compared to the first setup that I mentioned earlier and the second setup that I mentioned earlier, which is I personally think is actually, if you go deeper in this kind of innovation and do a physiological study, proper physiological study, it makes sense and it should probably help us with our current problem. Right. So I mentioned earlier, if you want to use the helmet with ventilator, okay, with ventilator, the usage is almost similar to your BiPAP. Okay, you must remember the larger internal volume. Okay, there will be increase in larger internal volume, and of course, okay, patient breathe in and breathe out. When a patient exhale, it produces carbon dioxide, and when patient inhale, patient will actually inhale their own carbon dioxide that been removed from their lung. This is called a lot of carbon dioxide rebreathing. Right. This is actually the study in 2011 looking at the whether effective dead space is related to this internal gas volume. They found it's actually not. Okay, it's not related to any internal gas volume, including the interface, okay, etc. So what makes different? Okay, what makes different? What is the thing that makes different? If you want to use helmet CPAP, it's actually the flow. Okay, the flow. Okay, this is actually published by physiological study. What they want is if you increase the flow to the possibility of carbon dioxide. What I'm trying to say is actually the number, if you want to use helmet, the fresh gas that going rushing into the helmet must be more than 40 liters per minute. Okay, if you don't get 40 liters per minute, patient will inhale their own carbon dioxide and cause a lot of carbon dioxide breathing. Okay, so the magic number will be 40. Okay, one might say, how do I know? Because you can't measure. The most easiest way to look at it is actually you look at the helmet. If your helmet is not inflated, you know the flow is not enough. Okay, so it reflects the whole fresh gas that rushing into the helmet is less than 40 liters per minute. Right. So number two, you can't use helmet CPAP to deliver. You can't use ventilator to deliver helmet CPAP. Why? Yeah, why? This is actually a study published by Tacconi in critical care medicine in 2004. Okay, what they found is actually looking at helmet CPAP with ventilator versus helmet CPAP with continuous high flow system. Okay, this is the what that we use. Remember the step 1, step 2. Okay, setup 1, setup 2. This is actually with ventilator. What they found is helmet predisposed to carbon dioxide breathing and should not be used to deliver CPAP with ventilator. Right. So if you want to use this ventilator, minute ventilation and partial pressure of CO2 should be monitored. Okay, during CPAP with helmet. So this is a problem. Okay, if you want to use setup 3 that I mentioned earlier, because of high compliance of this helmet, okay, it caused a lot of delay in terms of ventilator assist. It caused a lot of a problem with triggering, and of course, it caused a lot of ventilator asynchrony. Why is that? Remember basic physics. Okay, when you start giving, okay, when you put patient on ventilator, what happened? First phase is actually the ventilator have to fill up the helmet first. Okay, and of course, the trigger for most ventilator, okay, is actually volume or pressure. Okay, then only it goes to the lung. Okay, so this creates a lot of auto triggering or double triggering. Okay, in helmet CPAP they use with ventilator. Right. This is another interesting study published by Chumelo. What they found is actually they compare helmet CPAP with continuous airflow, face mask with continuous airflow, helmet with ventilator, and face mask with ventilator. What they found is actually there's no difference. Okay, we would like to think. I think the early phase of helmets usage of helmet CPAP, people quite skeptical about whether helmet will actually change the breathing pattern and increase work of breathing, and eventually patient will get this respiratory fatigue and causing NIV failure. Okay, so this study have proved there's no difference in this thing. And of course, the keyword if you want to use helmet with ventilator is pressure support. Okay, pressure support. And this is actually a study by Maioli, published in 2008. You can see here this pressure support. Okay, and this is actually the CO2. By increasing pressure support, you actually reduce the possibility of carbon dioxide rebreathing. Okay, so how to do it? I will try to make it simple for you all. The problem, if you use helmet with ventilator, you need number one, you need your inspiratory and expiratory limbs. Okay, one into, one out. Okay, and because the ventilator have to fill up the helmet first, it causes a lot of slow in terms of pressurization. Okay, and once you fill up, okay, it causes a lot of problem with the end to actually determine what is the end of the inspiratory phase. Okay, so it causes a lot of slow in depressurization. So you have two issues. One is pressure support will be weak, and you have a trigger issue. Okay, how to deal with this? This is actually suggestion by Laurent Bouchard, published in Critical Care in 2009. They suggest, okay, because of to deal with this slow pressurization, you first increase the RAM, okay, so it become more, okay, acute, okay, and because of the other issue of this, okay, you increase your PEEP by 50%, yeah, and you increase your pressure support by another 50%. Meaning, if your usual, let's say, is 10, so you need to increase your PEEP to 15. And you need to increase, let's say 10 is your usual PS, pressure support, you need to increase, let's say 15, right? Okay, this is actually another way to do it. This is actually published quite recently in JAMA, I think a few weeks ago. And based of the intervention, it's quite interesting. The base the intervention that they use in their methodology in this randomized control trial is quite interesting. In which, for those who actually use the high-end ventilator, for example, I am not connected. I'm not biased with the brand. You have this Lowenstein, you have Hamilton, you have this Bella Vista. They have this. They call it NIVST. So what you can control in this is actually you adjust your inspiratory trigger, okay, and also expiratory trigger, right? Right. If you ask me, okay, I would like to mention my first word. Use the setup 1 first, setup 2, familiar with it, okay. In some cases whereby you want to use something, not really the BiPAP version, okay, using helmet. This is what you need to do, okay? Change the inspiratory trigger, make it faster, the RAM faster, okay? Number 3, adjust your pressure support, take somewhere around 50%, okay? Okay, and of course, dial properly your expiratory trigger, right? And of course, your PEEP increased by 50%, right? Right. I hope I didn't confuse those who never use helmet CPAP with that helmet used with pressure support with CPAP, right? Okay. The other disadvantage of helmet CPAP is actually it exceed the noise is exceed more, sometimes more than 100 decibel. Okay, and of course, this intense noise intensity is fully affected by pressure support level. Okay, this is actually the evidence that is actually looking at this noise exposure during helmet CPAP. So what we normally do in our department is actually to put the HMI filter there. Okay, by doing this, we can actually reduce the noises that goes into the helmet, right? With this era, COVID era, we actually put another HMI filter out of it before it's actually going out from this just before the valve. So you have HMI filter here. Another you have another HMI filter. Yeah. So you have 2 HMI filter, especially in COVID patient. So another advantage of this helmet is patient can drink, okay, patient can eat. There is a kind of outlet, okay, in front of any helmet apparatus that allow patient to be fit and to drink. Of course, you can't ask patient to smoke with helmet CPAP, right? Okay, this is actually the one that is presented by Dr. Azli just now. Okay, a lot of people asking me whether you can actually do a wake prone in helmet CPAP. This is actually study published quite recent. Okay, recent a few weeks ago. Sorry, in Lancet Respiratory Medicine, looking at the feasibility and physiological effect of prone position in COVID patient. Okay, using helmet, you can see the in terms of the advantage and benefit in terms of oxygen delivery interface, right? Okay, when we talk about NIV with helmet versus control study, okay, based on the 11 study on almost 600 patients, is reduced mortality, something similar. And what is actually important of us is actually this patient-centered outcome, which is reduce the intubation rate and also reduce in terms of complication. Okay. You can use it hypoxic acute respiratory failure. Okay, this study by Antonelli found there's actually oxygenation is higher in patient who receive helmet CPAP. Okay, and this is our own study published quite recently, a few months ago, published in the American Journal of Medicine, whereby we're looking at the different between the CPAP helmet CPAP that was set up. Remember, set up 101 that I mentioned earlier. To face mask CPAP, okay, for treatment of acute respiratory failure emergency department, and we're able to actually randomize, okay, almost 100, more than 110 in both arm, 118 in helmet arm, and 131 in face CPAP. And what we found is quite interesting that those with face masks, they have increased rate of NIV failure that we need to intubate. So intubation rate is actually quite high in face mask compared to helmet CPAP. And what we found in this is actually inferiority, inferior randomized control trial. What we found is actually helmet is actually better in reducing the respiratory rate. Okay, it's better in terms of reducing the heart rate, and of course, okay, it's quite tolerable in terms of dyspnea score. So this is actually the early study that using helmet in acute cardiogenic pulmonary edema, published by this group of researchers from France. What they found is that also one of the senior author in this study is actually Professor Antonio Pesenti. What they found is actually the helmet CPAP with helmet CPAP and standard medical treatment with face mask. With helmet CPAP, it improved in terms of oxygenation. It reduced the respiratory rate and also reduced the heart rate. This will be published in the next few days. Will be accepted and pending publication in European Heart Journal. Okay, I was told that we publish in the next few days. We're looking at the helmet CPAP versus high flow nasal cannula, FNSC, in specific pathology in acute cardiogenic pulmonary edema. This is a randomized control trial. And what we found is quite interesting. Okay, in terms of respiratory rate, okay, it reduced the respiratory rate, and of course, it reduced the PF ratio, which is very benefit. Okay, for patient that presented to us, especially in hypoxic respiratory failure, for example, due to cardiogenic pulmonary edema, and of course, it improved in terms of HACO score and dyspnea score, right? And of course, the main indication for this patient, this study for intubation, you can see there is different in terms of a number of endotracheal intubation in helmet compared to in patient with high flow nasal. What we can conclude is actually helmet CPAP is way better than high flow nasal cannula in acute cardiogenic pulmonary edema. We personally think the reason why helmet CPAP is better than high flow nasal cannula is actually helmet CPAP is able to deliver high peak. Right? If you look into the physiological study on high flow nasal cannula, the maximum peak that you can actually achieve with high flow nasal cannula is actually probably around 5 to 7. It's in ideal patient, okay, with the normal, what I call it, anatomical and physiology. Right, but with helmet CPAP, you can go up to 20, in fact, which is might benefit in patient with acute cardiogenic pulmonary edema. So you can use it immunocompromised patient. Okay, I've just go glance through. Okay, and of course, this is actually in ARDS. This is actually one of the landmark study published by a group of researchers from Chicago, led by Dr. Patel and Dr. Kress. Okay, Professor Kress. Of course, it is early, terminated early, okay, but the finding is quite interesting, whereby the statistic data, okay, study have shown it reduced the mortality rate and reduced the intubation rate, which is a kind of patient-centered outcome for us that they work in emergency department. Right? This is the first study. Of course, there's subsequently there's a lot of study which published quite recently a few months ago, whereby they look at the effect of helmet compared to high flow nasal cannula in patient with COVID-19. In fact, the participant in this study is those with moderate to severe hypoxemic respiratory failure due to this COVID-19, published by Domenico, and the senior author is actually the Professor Maximo Antonelli, published in JAMA. Right? The question the one to actually answer is actually among patients with COVID-19, whether this helmet CPAP compared to high flow nasal cannula will actually benefit patient. The primary outcome that they actually use is actually the median number of day free of respiratory support within 28 days. But even though it's actually a negative result in terms of study, they found there's no difference between helmet and high flow nasal cannula. But if you look into some of the parameters, I personally think that by choosing a better in terms of patient-centered primary outcome, it probably result in different conclusion, right? So even though it's not significant, but looking at the ability of what I call it helmet CPAP to deliver higher PIP, I personally think it might be benefit in especially patient with ARDS, especially patient with COVID-19, right? So of course, probably somebody have to do another study looking at different outcome, patient outcome, probably the intubation rate more bigger in terms of power, study looking at this intubation rate. That's my personal opinion, right? So in summary, major advantage of helmet, I mentioned earlier, it's lower in a leak, okay? Most of the time, we don't see a facial, I never seen one since 2010 that we're using helmet excessively for NIV. In time, we actually use helmet exclusively for NIV, right? During the pre-COVID era, okay? And we never seen a patient with eye irritation, okay? And independent of patient anatomy, right? Disadvantage, as I mentioned earlier, a lot of noise, but we have ways now to actually reduce this noise with helmet CPAP by putting a HMI filter before the fresh gas enter into your patient helmet, okay? And of course, large dead space, which is overcome with your flow fresh gas more than 40 liters per minute, okay? And this synchrony that I mentioned earlier, there's a setting that you need to, there's a way to actually optimize your ventilator setting if you want to use the helmet with ventilator for BiPAP, right? And of course, this is actually the suggested given for, okay? So, I will like to repeat my statement. If you want to use a continuous flow CPAP, use this, okay, for beginner. The inspiratory gas flow must be more than 40 liters per minute, and you need to adjust a few things: your PIP, your pressure support, and also your RAM, okay, to maximize your pressurization rate if you want to use it with ventilator. Right. This interesting algorithm published in CHEST quite recently. Okay. They're looking at this algorithm. What make me interested in this algorithm? You can see awake proning, okay, alone or with helmet or NIV, okay. In non-invasive, consider helmet, right? I'm sure in the next few months there will be a lot of study looking at the role of helmet, especially in COVID-19. Okay, that's it. Okay, I will love to answer any question in the QA chat box. Right, thank you very much. Okay, our next presenter is Dr. Azma Haryati Ahmad. She is our consultant emergency physician, so fellow in emergency critical care, and he just finished her fellowship attachment from Israel Medical Center, Harvard Medical School, right? And she's going to talk about how to monitor patient in NIV, okay, especially for COVID-19. Without further ado, I would like to invite Dr. Azma.
Assalamualaikum and a very good morning. Thank you very much, Dr. Adi, for a very nice introduction. So we are going to continue our next lecture or webinar focusing on the monitoring of NIV in COVID-19 patient. So as usual, I have nothing to declare, and this is going to be the workflow of my presentation. I'm going to talk more on general monitoring measures and specific monitoring measures for COVID-19 patient and monitoring specifically in NIV patients. And I hope we have more on junior medical officers and paramedic listening to the talk, because I think they are the ones who are actually doing most of the monitoring job. If you're putting the emergency physicians or the registrar on the floor, they tend to come up with the management or plan of care, and then went to the next patient. So those actually going to do the monitoring is this group of people that we really hope they are here and listen to the lecture. Right. So as you all know, we've been facing this COVID-19 pandemic for the last 2 years. And I think at this point of time, it's not only the illness itself that create a problem, it's now the sequelae or the complications of COVID-19 that now becoming the pandemic complications. So if you can see here, instead of only dealing with the COVID-19 disease itself, we have multiple complications that affect our patient's neurological point of view, respiratory problem, cardio problem, secondary bacterial infection, for example. So all these things lead to either the temporary or the permanent complications to all these COVID-19 patients, right? As a brainstorming, what does it mean by monitoring? The aim and the philosophy of monitoring is basically looking at the welfare and treatment of patients and its progression from clinical resuscitation to the early detection and prevention of clinical catastrophe. All right. So if you look at the picture, that we required multiple tiers, multi-level of involvement in doing this monitoring. And as I mentioned before, we basically depend more on our junior medical officer and paramedic to do this while we are doing the plan of care to these patients. So I think that this group is the one that we really need to focus on. And can we do adequate or standard monitoring in emergency department? I know all of us wish that all the COVID patients being admitted to the ward as soon as possible, we admitted to ICU as soon as possible. Even for the previous year, we took a standard of less than 6 hours for patient to be in ED and to be pushed to the respective ward or respective department as soon as possible. So this is the problem that we face in ED, because we know those patients in COVID-19 stay longer and longer in ED. Sometimes it took up to hours, and in my center can goes up to days, even 4 to 5 days. All right. So these are the things that we need to focus on now, on how to look on how to monitor this patient. Instead of putting the patient in 6 hours, we need to care beyond that 6 hours in ED, and how to deal with the incoming new patients, how to deal with the lack of manpower, how to deal with the lack of knowledge in our emergency department. Right, so let's start about thinking about on how to do monitoring. So you need to think about the plan of care that been given, been planned by the specialist or the registrar that doing the round, or by the other departments that actually suggest for you to take care of the plan in ED, right? And then you need to start thinking on the progression of disease, the setting of the equipments, and the availability of manpower. And maybe in the near few hours, this patient, after they went off this treatment plan, you need to start looking or assessing the complications of disease and treatments. And you need to have a look at the failure of equipment and the exhaustions of manpower. We know this is the current problem that we face nowadays, where all the manpower is exhausted, but it shouldn't compromise the care of the patients. So that's the three things that you need to focus on: the patients, the equipment, and the manpower. So how to do the steps of monitoring and evaluations? First, you need to recognize the patients, the manpower, and the equipment that you want to use. And what is the plan of care for these patients, right? And then risk assessment. Have a look at the patient's hemodynamic clinical parameters, the patient's scoring index, if there's any, the indication or the contraindication of NIV or other types of interfaces. And you can start using the NIV scoring index in order to determine the improvement or the failure of NIV itself. And then measures the parameters. Right, the parameters are divided into few types of parameters. You have clinical, you have hematological, you have laboratory parameters, radiological parameters. All these things are very, very important for you to do use it in your monitoring. And the time allocated, certain blood investigation can be done daily, certain need to be repeated within 2 hourly, 4 hourly. So all these things are very, very important as well. And what are the continuation of care? We are lacking on this continuation of care, the transfer of information from one shift, from one personnel to one personnel, from another shift to another shift, from our department to the other departments. So these are the things that I think we need to focus on. And what are the clues, the hidden clues that we always, especially the juniors or the paramedics, most of them are lacking on this. The hidden hemodynamic parameter, for example, the shock index, the PF ratio. All right. So what are the failure of NIV, the HECO ROX index again, post treatment, and then we have look at the developments of COVID-19 complications such as neurological cardiac thromboembolic events. So these are very, very small clues sometimes we miss during our monitoring in COVID-19 patients, right? And then you need to have a target by the end of your monitoring. What is the target? The target can be seen by looking at the improvement in patient's complaint, the clinical, hemodynamic, blood, radiological, all right, and the oxygenation targets. What are the things that we want to aim, all right? What are the mean arterial pressure that we want to aim? And then you need to target in updating the daily census, because some of the patients stay longer in ED. Sometimes we miss transferring these informations to our colleague from other departments. So sometimes they miss that patient. So all these things are the target that you need to do by the end of your monitoring. Right. So we go to the parameters. Okay. So have a look at the clinical parameters. Monitoring of clinical parameters is primarily intended to detect changes or absence of changes in the clinical status of individual. You can look at the patient's circulations, but have a look at the patient's excessive sweating, for example, to assess the severity of respiratory rate. For example, if the patient become more distressed or the patient improve in respiratory rate, have a look at the color changes and have a look at the change in the mental status. And all these clinical parameters need to be assessed within 15 to 30 minutes, or if there's any changes noted in all NIV patients. So what about hemodynamic parameters? What differ from clinical? Hemodynamic parameters is basically measuring the pressure of the heart, with focusing on the important in heart-lung interactions. So these are the things that we take most of the time, day-to-day basis, most of the time we're talking about an IV patient or patient in critically ill patient, we do this continuously. So you can take the continuous blood pressure, you can take monitor the patient's pulse oximetry, the pulse volume, ETCO2, and also the cardiac monitoring. So these are the things that we need to do more continuously, but even though it's continuously, there's certain values that you need to inform or you need to mention to the superior if there's any changes or there's some form of alarming values, if there's any, right? So what about the scoring index? This is one of the regular scoring index that we've been used in emergency department. Is basically used for acute illness severity in critically ill patients. You have the National Early Warning Score or NEWS. All right, they got a few parameters for you to measure. So these are taking from the clinical and also the hemodynamic parameters that I just mentioned just now. So you calculate the parameters, the score, lump it together, and the score is basically used to improve the assessment, the detections of clinical deterioration, and also can be used to initiate a timely and competent clinical response. So if there's an increase in the score, the frequency of monitoring should be increased to a minimum of every hour for those patients with aggregate score of 5 to 6, or if the patients have presented with a red score of 3 in a single parameter. For example, if they have SpO2 of less than 83, so you need to increase the frequency of monitoring to at least a minimum of every hour. And this patient need to have a continuous monitoring if it's a score of 7 or more. And as I mentioned just now, the news can be used to look at the clinical response as a trigger threshold, in where if the patient presented to you with a total score of 7 or more, you need to have a continuous monitoring of water signs, and this patient should be monitored in a critical care zone, right? What about the score that can be used in COVID-19? That the news most of the time we use for critically ill patient, but because nowadays we're focusing on COVID-19, they're producing a lot of score on COVID-19 severity index. So one of these was basically adaptable from a new score, right? In exceptions, they add on a few parameters such as heart failure, so OPD, diabetics, meaning the patient's background or comorbids. They're looking at the chest X-ray parameters, they're looking at the deep SNP score, and they're also looking at the laboratory parameters such as D-dimers, lymphocyte count, and platelets. So the adding together of this score come out with the table next to it. Anything score 8 or more. Remember, news is 7 or more, but this one they adding more 8 or more score. This patient is deemed to be critical patients, and the continuous monitoring need to be done, right? For those patients between 6 to 7 score, you can done the monitoring, nursing surveillance every 2 to 3 hours. So we have these types of patient in our respi zones, right? So you either can choose your patients on NIV or your COVID-19 patient based on the COVID-19 severity index. So how frequent that you want to do the monitoring. Or you can use this COVID-19 decision support tool. Okay, this COVID-19 decision support tool, we've been using it in Ipoh for all the COVID-19 patients. It's actually help you in making decisions and to help you in decide what are the treatments that you want to give to these patients. Okay, it consists of 3 parameters: the age of the patients, the clinical frailty scale, and also the comorbidities, right? So all the parameters have their own points. You add on all the 3 parameters. If it's female, you need to -1, right? So total number, anything less than 8, you need to give an ICU-based care to these types of patients, all right? So meaning that I know the patients, as I mentioned, our patients stays longer, up to 4 to 5 days. Patients supposed to go to ICU, but they stays in ED. So you need to bring the ICU down to emergency department, meaning that you don't bring the intensivists down, but you yourself need to carry the patient as high as the level of ICU, right? So if the patient goes to group 2, where the score is beyond 8, so what you need to do is you can do a medical ward-based care, all right? So at this, have a look at the notes next to the group 1 and group 2. You can see these types of patient, if there's any failure of the first line treatments, you can use the step 3 in the next box, in where you can do extra support and extra treatment that need to be given to these types of patients, okay? And also for those patients who start off with the group, if you have a look at the yellow box down there, group 2 more than 8 points, you can consider trial of NIV, all right? So for these types of patients, NIV is this COVID-19 decision support tool. NIV can be decided using this scoring system, all right? So what about the respiratory monitoring? As we all know, all these patients comes to us with a respiratory problem most of the times. All right, so the vigilant monitoring or respiratory status is warranted for progressions. And I received a questions where how frequent do you want to do ABG, right? The best practice is to do every 1 to 2 hours in the first 2 hours. And then just to ensure the effectiveness and the safe ventilations. And after that, you can do a daily or when needed if there's any changes. All right. If there's any way of not doing ABG, we can discuss after this. Okay. So, but the best is basically to do the initial ABG in the first 2 hours, just to have a look what is the best, basically what is the baseline and what's the main problem. All right. And then advocates a low threshold to intubations. If there's any signs of rapid progression, which are not due to underlying rapidly reversible cause, you need to decide for intubation, because sometimes patient on IV give us a lack of idea on how severe is the patient, because patient can open the eyes, patient can talk, patient can eat. So sometimes we take it lightly. We say this patient is not in severe or critically ill patient. Thank God COVID have stages where all these high flow nasal cannula patient is staged with higher number, at least 4A, 5, okay? We only have 5 score for COVID. So the number of 4, it just indicate these types of patient is severely ill patients, COVID-19, right? So what are the oxygenation targets? The main important is to avoid hyperoxia, right? Individualization of goals is important, but certain patient, like patient in COPD, might present it to you with a low SpO2, and those patients in pregnancy required a higher oxygens, all right? So it's not fit all right? So you need to decide based patient, individualized to one patient from one patient, okay? And then the weaning of supplemental oxygen, if higher SpO2 is achieved, need to be done as soon as possible, all right? So the first SpO2 that need to be achieved during initial resuscitation, you need to aim your SpO2 to be more than 94%. And during maintenance of oxygenation, aim your SpO2 to be more than 90%. And once it's been achieved, right, you need to start targeting to the lowest FiO2 to achieve the oxygenation goals SpO2 of 90 to 96%. Right, this is, as I mentioned before, do you need to do ABG all the times? All right, because sometimes this is the parameters that we always use to look for the severity in COVID-19 patients and the failure of NIV, right? So most of the time we use PF ratio to monitor these types of patients. But can you use other parameters? Because PF ratio require you to go require the patient to underwent the ABG taking. So it's very painful, it's very inconvenient, all right, time consuming. So I think the first 2 ABGs prior to the initiation of NIV and 1 hour after the initiation of NIV, you can take the first few ABGs, all right, just to have a look at the PaO2 of the patients and try to titrating the FiO2 based on that, right? Then you can get the initial baseline of your PaO2. But later on, over the times, you can do just a daily ABG, all right? In between that, you can do what we call as SpO2 FiO2 ratio, right? But the one thing about SpO2 FiO2 ratio, the first thing you need to do is basically to correlate the SpO2 value with a saturation value derived from arterial blood gas to ensure the accuracy of the SpO2 measurement, because we know this SpO2 has a lot of co-founders, all right? So SpO2 need to be confirmed first, right? And then SpO2 correlation may not be fixed over time. So you need to repeat correlation checks at some regular intervals, but I think no need to do it hourly. So because we check our ABG daily, so you can check your SpO2 to arterial oxygenation daily, so that you can use the SpO2 FiO2 ratio over the time. All right. So I think a lot of people has been talking about awake pronations, right? So awake pronation, I think even the previous speakers also been talking about this. From the point of view in monitoring the things about awake pronation is the monitoring of the frequency on how frequent we want to do patients on prone, when do we want to put the patient on supine position, how many times for each proning positions, and what are the monitoring or what are the complications that associate with the awake pronations. All right, so different centers has different views on how long you want to do pronation. It was advisable to do 6 to 8 hours prone in 24-hour period. Certain centers do it 3 to 4 hours, but they make it twice daily. All right. And then these are the things that you need to monitor: the hypotension and the arrhythmias, transient oxyhemoglobin desaturation, compressed vasoactive medication, and supraventricular tachycardia, which is most of the time is transient. So we have a lot of others, but most of the time when we are talking about an IV patient on high flow nasal cannula, they are awake, they can move themselves, they can put themselves in supine position or in left lateral. So the part of monitoring in those patients on awake pronation is maybe less, right? So you need to assess also the risk factor that can lead to the failure of this awake pronation. For example, is male, gender. I do not know why male associate with failure in awake pronation. The age, elderly patient, and if the patient have a very big body mass index. Right. So how do we want to monitor the respiratory in awake prone patients? So the most important things again to monitor the clinical and hemodynamic response to prone position, ABG 1 hour and 6 hours post prone. As I mentioned, some centers are doing it 3 to 4 hours, but twice daily. Some centers are doing it 6 hours straight and then they put back patient on supine. Certain centers are doing it more prolonged, they continue up to 20 hours. If the patient's been continued on prone for 6 to 20 hours, you need to repeat the ABG 4 hours after the patient been returned to a supine position. All right. And how do we want to look for the response in prone position? You want to look for the patient PaO2 FiO2 ratio. The patient is is considered respond to a weak prone if the value is increased by more than 20 millimeter mercury from baseline. And also you can have a look at the PaO2 itself if the PaO2 level goes beyond 10 millimeter mercury of baseline, right? So this is just to shows the prone position is working for this patient. If it's not working, so then the next decision to intubate this patient need to be discussed, right? And then these are few things also on how to incorporate our lung ultrasounds in NIV or in a high flow nasal cannula patient in all COVID-19 patients, right? So it can be used as a diagnostic, because most of the time when patient comes to you, we are no more using our stethoscope because of the risks of transmission. So we tend to use more and more of lung ultrasound as a part of diagnostic. And also it can be used as a risk stratification in predicting the NIV failure and monitoring to look at the improvement of the severity respond or not on NIV on high flow nasal cannula. All right, on how we want to do these lung ultrasounds in COVID-19, you actually scoring the findings based on the lung ultrasound finding that you saw. So if it's normal, you score as 0. If it's well separated B-line, you score as 1. If the patient presented with coalescence B-line at each region, you score it as 2. If there is a consolidation, you score it as 3. Right? So then we have few types of lung aeration score and lung re-aeration score. Most of the times, I think we tend to use what we call as lung ultrasound aeration score. Even though in my center, most of the time we do lung aeration score instead of lung re-aeration score. It's easier to focus on the aeration score itself. All right. So lung aeration score, also known as absolute score, you are dividing your one lung into 6 regions, the other lungs into another 6 regions. So you have 12 regions for your bilateral lungs. All right. So for each region, you have maximum of 3 score. So you have 0 to 3 score, depend on the lung ultrasound finding that I just mentioned in the previous slide. So if your normal is 0, if you have coalescence is 2, if you have consolidation is 3, right? So you add for each region in 6 region on the right, 6 region on the left, you calculate the score in each region. All right. So the total maximum number is 36. You have 12 region times 3, the maximum score. You have 36 total points. So that is the absolute score. So you need to do this prior, once the patients arrive, prior to the treatment and after the treatment. All right. So the documentation need to be done properly. All right. So you need to mention you are doing lung aeration score or you're doing the lung re-aeration score. So lung ultrasound aeration score, get the absolute score prior and after the treatment. You can see the difference. Either this patient is getting worse or the patient is getting better. All right. So a global is basically telling you a global picture of lung aeration, a total score of 36 points for bilateral lungs. Increase in score indicates a decrease in aeration, meaning that increase in score meaning the patient have a very bad lung. All right. So what about the lung aeration score? Is also known as comparative score. We rarely use this in my setting, in my center, we rarely use this. Most of the time we use absolute score, but you can use this. You can use a similar lung ultrasound finding, except now, let's say you have a look, the first region is consolidation, score of 3. If let's say you have consolidation after the treatment, the consolidation move to B2, all right, mean the lung finding now goes to what we call as coalescence of B lines. So you score it as 1 point, positive 1, meaning that it's getting better. So it's positive 1. If it's getting worse, meaning if the first initial region, let's say you are doing in R1, the first initial score is 0, which is normal. after the treatment, you see at the same region, you starting to look, you're starting to see the coalescence of B lines. All right. So this is what we call as -3, meaning that it's getting worse. All right. It's not getting better. So you put the negative value in front, so it's -2 because it's jumping from normal to a coalescence B lines, right? So this actually looking at how bad is the lung and how good is the lung. It's comparative score, we call it, right? So a lung score reduction of 5.5 points or higher, and a lung re-aeration score of higher than 8 score correlate with substantial re-aerations. Okay, so you can choose which one that you want to use. Some I think find it the lung aeration score is easier to use rather than the re-aeration score, right? You can use the chest X-ray, all right, but very difficult to send all this COVID-19 to chest X-ray, or if you really need to do this, you need to have a portable chest X-ray. X-ray people, radiographer need to come with a full PPE, so it takes some time to do this, all right? But it is useful in ED with the ultrasound or lack of personnel in interpreting ultrasound finding. And then also very important to look for other causes. For example, in spontaneous pneumothorax, very small, right? So what about the usage of cardiac monitoring? Right, all these are very important. You can look at the systolic function of the heart prior, diastolic function prior, fluid responsiveness prior to the treatment, right? So reassess again after the treatment, and you can also use this if the patient stays longer in ED to look for the evidence of COVID-19 complications, such as the presence of thrombus in pulmonary embolism, or if the patient develop cardiomyopathy, for example, or hypokinesia, because these are the things that worried us, all right? And then you can look at the progression of disease by looking at the worsening of the heart function. All right, so what are the supportive therapy? I think Dr. Azir mentioned about this. So we need to start thinking about the complications and the prevention or prophylaxis of problem in COVID-19 patients. For those because they have high chances to develop venous thromboembolism, so you need to do over and over checking on the lower limb discoloration, swelling, all right, or perform ultrasound 2-point compression, and then you can start the treatment if there's any evidence if the patient is less mobile. If you are talking about NIV patient or supine patient, maybe this is less likely to be started. All right. What about the stress ulcer prophylaxis? All right, need to be given if those patients are unable to tolerate orally or critically ill patient in where the enteric is delayed. All right, and if those patients already develop complications such as GI ulcer or upper GI bleed. And the optimal glucose control is very important, especially when the initiation of steroids. All right, the aim is need to be around 6 to 8 millimole. You need to start insulin boluses or infusions if blood level is more than 10 millimole per liter. And how frequent do you want to monitor? You need to get the baseline value and 4 hourly once feeding was initiated, or after the initiation of steroid hourly for the next 2 hours. All right. What about the other organ support system? This is a few. I think I got one questions asking about what types of analgesic or anxiolytics for you to start with patient on NIV when they are restless. You know, of course, when we are talking about restless patient on NIV, are we blaming the patients on hypoxia itself? So you need to reassess, is it really because of hypoxia? Because if the patient really hypoxic, the NIV might not be suitable for this type of patient. This patient should undergo intubations. All right, the best analgesic anxiolytic, this study published by Ellis in 2020, they talk about the usage of Presidex or dexmedetomidine in the patient in early prone position combined with hypronasal cannula in COVID-19 patients. All right. So this Presidex is the best. It's centrally alpha-2 receptor agonist, promotes sedative and isolating effects, but again, it's not available in ED. All right. So it's not available in ED. So what are the choices that you have in ED? You have ketamine, you have propofol, you have intermediate, you have your benzodiazepine, you have your opioids. So you can use this, but in a you need to know the indication, you need to know the contraindication and the side effect all of these medications. So the dosage need to be really, really small. You need to assess the patient's sedation after that, all right? So you can start off with a small dose and reassess every time you, the main important is basically to calm the patient. Or you can use a non-pharmacological method. Certain patients, if you wanted to start patient on face mask and IV, the instruction on how the patient deal with the high pressure is not really mentioned properly to the patient. So the patient tend to fight, so they did not receive the oxygen as much as they needed. So you need to talk calmly to the patient, give a proper instruction on how to deal with the face mask or with the NIV, right? So the other organ support system is the fluid balance, the BP control, the nutritional status, and the one other things that we also forget about this is the psychological and emotional support. I know we tend to use phone now to do video call with the family members, but I think this need to be addressed early when the patient come to you in the emergency department, when the patient still have a proper conscious level in full capacity in making decision. You need to ask further questions about what are the directive of care on these types of patients. Okay, all this documentation need to be done early. Right, so what about the fluid intake? All right, the goal of maintenance fluid therapy is to preserve water in electrolyte balance and to provide nutrition. We know in patient with COVID, they have this increased water intake where they have this high-grade fever, sweating, significant GI loss or tachypnea, and certain patient, when they've been put on hypronasal cannula, these are the indication where you need to reduce the water intake. All right, so what are the fluid balance that you need to aim? So you need to aim the patients to be more than 10% body weight, all right? Because less than 10% body weight. Anything that associated more than 10% of body weight, if it's positive, is associated with higher 1 year adjusted risk mortality. If it's negative, fluid balance is associated also with higher mortality after 42 days. It was less in the initial stages, but when the patient went up to the ward, when the patient went up to the ICU or the patient being discharged, the mortality is significant. All right, and this fluid balance is attenuated by the renal replacement therapy for both positive and negative value. Right. So one thing that we forgot about patient on NIV, because as I mentioned, they doesn't look very ill. They open their eyes, they can nod their heads, they respond to your call, to your speech. So these are the things that I think we neglect, the nutritional status of these NIV patients. Okay, so you need to assess the malnutrition of the patients. Okay, look at the increased energy consumption, the insufficient intake of nutrition, and the metabolic disorder if there's any, and risk stratify the patient. If the patient have higher risk of aspiration, look at the criteria that lead to this. All right, and then what are the things you need to monitor when the nutrition therapy has been initiated? As I mentioned, blood glucose after it has been initiated, and at least 4 hours in the first 2 days. And then what are the level that you need to target? The blood glucose target should be around 6 to 8 millimole. And what are the electrolytes that you need to have a look? So because some patient required electrolyte supplements, all right? So this can be done daily, first at the initial presentation and later on daily basis, all right? So as I mentioned, oral diets are preferred because we are talking about NIV patients. So if the patient is able to cover 70% of his needs from day 3 to 7 without risk of vomiting or aspirin, just continue patient on oral diet. But certain patient might not possible to start with oral. You can start patient enteral nutrition. This early enteral therapy need to be started within 48 hours. All right. And if possible in ED. I know we are not doing parenteral, so enteral therapy is needed if patient cannot tolerate orally, but it need to be delayed when the gastric residual volume is more than 500 ml per over 6 hours. So what you need to do prior to the initiation, you need to recheck how much is the fluid contents, and then you can I don't think it's a problem in patient with high flow nasal cannula. All right. So what are the complications of an IV? I think Dr. Adi already mentioned about this. These are the common complications. I depend on what are the interfaces that you use, but most of the things that you need to know is the failure of technique, because certain patients does not respond to high flow nasal cannula. Certain patient does not respond to face mask, CPAP. So what are the failure of technique? What are the parameters for you to say, okay, this patient is not indicated for these types of interface, and this patient need to be intubated. All right. And the other things that we need to monitor is the complications of COVID. These are the things I think we also rarely focus on, because patients tend to stay shorter in ED. But I think these are the few things that you need to start thinking, because the patient stays up to days in ED, so they can develop the complications of hypercoagulopathy, neurological, GI, cardiovascular, respiratory failure, and secondary infection. So all these things need to be reassessed. So you need to do the history and clinical examination over and over again. So I think this is very important. If we can assign one medical officer or one staff to just have a look at the patient's reassessment of the history and clinical examination. And what about the hematological? So hematological can be done daily, comparing between the initial hematological to the 24 hours changes. All right. So increase in all these parameters and reduction in absolute lymphocyte counts is associated with the severity or worsening of the COVID-19. Okay. And then what are the radiological examination that you can send? CT brain, high resolution CT, but I think again is rarely indicated unless the patients are presented with neurological complications. All right. So the bedside things that we can do is, as I mentioned, the focus, the lung ultrasounds, and 2-point compression lower limb to look for all these complications. So this can be done early. I think it can be done early. It can be repeated multiple times in ED, but the things is we really need to have someone or assign the medical officer to do this so that we didn't miss the complications of COVID. All right. So what about the hematological parameters? As I mentioned just now, all these laboratory features are associated with severe COVID-19, dose elevations of D-dimer, CRP, LDH, troponin, ferritin, CPK, but Dr. Sabrina already mentioned about this. Not all the hematological parameters we do in ED. All right. So even, for example, the dimers, certain ED have quantitative measures, certain ED only have qualitative measures. So if you have qualitative, yes or no, positive or negative, it might not be so significant because we already know this patient COVID have some form of infections that can cause increase in the elevation in the dimer. All right. So you need to think about other diagnoses which can affect the raise of the value. All right. So the increase in these hematological parameters is associated with severe disease, but it does not demonstrate to have really prognostic value. So you need to go back to your patients again and have a look. All right. What are the additional consideration? Escalating oxygen requirement or sudden increase in oxygen requirement. Please think about all other pathological events such as acute cardiogenic pulmonary edema, myocardial infarction, or pulmonary embolism. All right. So what about the equipment? These are the things. So most of the time we know how to start patient on an IV, but we do not know how to handle this patient on an IV or handle the equipment, right? So first, daily checking, or the best is shiftly. All right. by shift, checking the equipment, check all the ventilator settings and the alarms, have a look at the connections, check the tubing for kinking and mask for leaking, all right? And then if you're using high flow nasal cannula, look at the temperature setting on the humidifier, look at the water level, all right, inside your humidifier, all right? And then certain patients have, certain hospitals have equipment policy where they need to do a ventilator circuit and change, so it will depend on your setting. Maybe you want to use it, but only change it when there's some problem with the equipment, all right? And the other things is the setting on the CPAP or high flow nasal cannula. This is one of the things that we rarely do, where most of the time when they're starting patient on high flow or helmet CPAP with the similar PIP for the next 6 hours, they are still using the similar PIP. So maybe in these types of patient, if you have look at reassessment, the clinical and hemodynamic parameters, if the patients are maintaining or improve in clinical or hemodynamic parameters, you can adjust the PIP that been delivered to the patient by 3 to 5 centimeter water. All right. If, for example, if patient is not desaturate, so you can increase more the PIP of 3 to 5 centimeter water every 20 to 30 minutes. All right. So, and then patients, clean up the patients because it stays longer with us, meaning that need to maybe have a tepid sponging on patients, clean up, change the patient's wardrobe, all right? Meaning you need to really make sure the patient is appear healthy and clean, right? And then the multidisciplinary team, make sure we need to update the daily census to our teams, to the ICU teams, to the medical teams, and also need to inform them about the progress and plans that been associated with the patients. Again, right, there's no black and white about monitoring. I know it's very difficult, it's a big topics, but again, as a summary, these are the things that you need to think of when you do monitoring and evaluations of patient in COVID, patient on NIV, and patient in general, all right? So think about the patient itself, think about the equipment, think about the manpower, all right? Because these are the things that is very, very important in monitoring. So what you need to know is what to do, when to do, and how to do it correctly. With that, I thank you. So, all right, so we are going to continue our next presentation with Dr. Shaliza Samsudin. She is currently a fellow trainee in emergency critical care in Hospital Raja Permaisuri Bainon. She's going to talk to us about NIV failure. So Dr. Shaliza, the floor is yours.
Assalamualaikum and a very good afternoon to all of the audience out there. Can you hear my voice clearly, and can you see the PowerPoint?
Yes, Dr. Shaz, we can hear you.
Okay. So I think I will continue with another topic of NIV for COVID-19 in terms of how to determine NIV failure in COVID-19. After we basically listen for long talks for today, how to use the NIV, when to start the NIV, how to monitor, and now come into the important aspect of how to determine when to escalate the NIV to invasive mechanical ventilation. Then my outline of presentation will include respiratory support in COVID-19. I think most of the speaker already talked about it before. And second thing actually is when the right time to intubate hypoxemic patients with COVID-19. This is one of the most important things in COVID-19 patients, and how to predict NIV failure, so that we need to escalate the therapy to the invasive mechanical ventilation. And the last one, the take-home messages. So I'm sure that you know and familiar with this table, in which it basically tells us the severity actually is correlates well with time course, in which the more severe the disease, they basically develop the complication of the COVID-19, include the ARDS. They can have mild, moderate to severe. They also can have multi-organ dysfunction. They can have hemodynamically unstable patient, and also they basically can come with cytokine storm. And those kind of patients related well with severe form of diseases. And when you see at the categorization of the disease, the more severe the disease, the requirement of respiratory support will be higher. You can see at the end of the stage 3, most of the patient will have a low flow oxygen therapy. And when basically they enter the category 5, in which in the phase of the hyperinflammatory phase, in which they actually develop some form of the complication related to COVID-19, actually the requirement much more higher. Either they require non-invasive ventilation, or in some patients, they will have a failure to NIV in which they require mechanical ventilation. And this kind of patients, we should monitor properly in terms of the progression of the patients to the severe form of the diseases. When we talk about escalation of respiratory support, as I said before, it depends on severity of the disease. That is number one principles. And you can see the range of the respiratory support in COVID-19. It either you can start low oxygen flow, or you can just titrate up and step up the respiratory support to much more higher oxygen concentration, in which you can either start the face mask up to 5 liter, and some of the protocols use the non-rebreathing bag up to 15 liter. And if you basically patient is still persistently hypoxic, then you need to escalate the patient to some form of NIVs. Either you start high flow nasal cannula, or you can start CPAP or BiPAP. It depends on whatever available respiratory support that you have in COVID-19. And some of the patients actually not respond very well with NIV and might deteriorate according to the severity, and they require invasive mechanical ventilation. And some of the patients, despite the invasive mechanical ventilation, they actually progress further and require ECMO. And whatever the respiratory support, basically we decide for the patients. As Dr. Azma said in the previous lecture, more important, we need to monitor properly about the progression of the patient, because the principles of the respiratory support involve these 4 components. Number one, whenever you start respiratory support, our aim actually to promote lung homogeneity. But you should remember, this is not only delivered by respiratory support, you need to combine with a wet prone and other respiratory and also medication that basically can help in terms of to make the patient better. Second thing, actually, with giving the respiratory support, we can correct the hypoxemia, and also important to ablate the high respiratory drive. Why it is important? Because some of the patient, despite we start some form of NIVs, they basically still have persistent respiratory rate higher, in which this actually will cause the self-inflicted injury and cause the vicious cycle of the lung injury. And also not to forget that the aim of the patient, especially in mechanical ventilated patient, we want to minimize the stress and strain injury so that patient will not progress to severe form of disease. In early year of COVID-19, before March 2020, we know that initial clinical guidelines recommended early intubation approach in all COVID-19 patients. And by using a very low threshold of low flow oxygen up to 6 liter, they use this as the criteria for intubation because they're afraid of NIV due to aerosolization issue. And number 2 actually is because of the thing that the patient with COVID-19 will have very fast deterioration in terms of respiratory support. That is why most of the clinicians use early intubation approach. And this has been consistent with one of the report by the REVA network in 2020. We can see from here, numbers of patients involved was about 4,000 COVID ICU patients. And you see at the trend and the graph, at initial phase and wave of the pandemic era, so you found that you can see that the trend actually is towards intubating the patient early, rather than after April 2020, more high flow nasal cannula and NIV used during the second wave, because they actually understand the disease more, and they found out that the benefit of the NIV basically can prevent the patients in terms of to reduce the intubation rate, as well as because of resources constraint, we use quite a lot the ventilators. The numbers of patients to take care of the patients with mechanically ventilated patient is quite high. That is why basically the paradigm of the management of patient has changed so much from March to April 2020. And the lesson from COVID-19 pandemic with various of the countries, you can see from here, mortality rates for patients requiring intubation appear to be high, as high as 50% to 80% whenever patient require intubation. And another experience by Jiangsu province that has been published in Intensive 2020, they highlighted that early recognition of high-risk patient and the early intervention actually can prevent the progression of disease. And how basically they can prevent the disease, the progression of disease, actually by initiated the NIV much more earlier in the care of the COVID-19 patient who develop hypoxic respiratory failure, in which by giving NIVs, it can prevent alveolar collapse. And this actually has combined with another approach, which is fluid restriction strategy and also early awake proning, in which in totality, they found out that less patients end up with the mechanical ventilated, underwent to mechanical ventilation, in which when you see at the numbers that patient require invasive mechanical ventilation is much more lesser than the national average of 2%. And if we can see from the various guidelines that endorse the use of the NIV, either you use the high flow nasal cannula and either types of NIV, there are a lot of guidelines that basically recommended to use the NIVs. For example, the CDC, the Society of Critical Care Medicine, WHO, and other guidelines as well from many countries. And yet, I just want to highlight one of the guidelines by the SCCM, recommended that usage of NIV high flow nasal cannula as the first line support for COVID-19 patients that develop hypoxic respiratory failure. If you can see at the step up management from the first thing whenever you encounter a patient with COVID-19 patient who basically have desaturation, the first thing to do actually to find any indication for endotracheal intubation. That is the first important things that you need to do. If the patient develop imminent respiratory failure or they come to you very severe disease, then you basically can initiate early intubation, because delayed intubation associated with the worst outcome. And if the patient have a mild to moderate category of diseases of COVID-19, you can start with the low flow oxygen, you can titrate up, and if the patient is still hypoxic, not to reach the target of SpO2 of 92 to 96%, then you can think to escalate to further respiratory support, in which you can start high flow nasal cannula, or you don't have high flow nasal cannula, you can start with non-invasive strategies, for example, the CPAP or BiPAP. And more important, after you initiate any form of respiratory support, you need to monitor closely the patients to predict the likelihood either the NIV will be success or the NIV will be fail. So that is why if you notice in one of the component over the right side of the box, the only target that you need to maintain actually to target of the SpO2 of 92% to 96%. And I'm sure that you basically don't really agree with this one particular important target, because we have many more parameters that we need combine, not only looking at the SpO2 92%, because of why we know that the COVID-19 is very unique, even though they basically hypoxic, but remember they can come to you with a silent hypoxemia, in which they basically can still not, the RR is not so high, they basically quite comfortable, but they have severe desaturation. In this kind of patient, when you see and evaluate back to intubate the patient who actually remains conscious, hemodynamically stable, and still playing around with the phones, it is quite a challenge for us to decide only using with one target in which a saturation oxygen. All right, that's why the timing of the NIV versus mechanical ventilation is very important, because there are a lot of benefits related to NIV. Even so, if you basically prolong the usage of NIV for unnecessary patients, this actually will cause an initiate patient to develop a PCL, in which is a self-inflicted lung injury, in which this actually make the disease become worse. So that is why we need to really balance the strategies in both two, when the patient or which patient basically we can start the NIV and which patient basically can we initiate early intubation. So we should also remember that in a patient who basically require early intubation, if we actually delay the intubation, it also have a worse outcomes. That's why the timing is really important. Decision for timing for escalation of respiratory support from non-invasive mechanical ventilation to invasive mechanical ventilation obviously is challenging for all clinicians, not only in emergency department, also in the intensive in ICU or any medical physician also have a similar challenge. So identification and prediction of NIV failure is of great importance. Right. So we go back to the principles of how basically we want to make sure whatever we give to the patient will be success or fail. By doing this thing, the first thing actually to select the right patient, the right intervention and the right time. That is first, number one, based on the indication, contraindication that the previous speaker already talked about it. Okay, the second thing, actually about to predict the risk of NIV. After we initiate some form of NIV, then what more important actually to predict the patient who has likelihood of the failure of NIV, and we need to start the respiratory support to escalate to early intubation approach in that kind of particular patients. So you can see from here, okay, the first thing, as I said, ask yourself, either the patient fulfill the criteria of early intubation approach, in which patient with severe respiratory failure, in which most of the time we see at the saturation oxygen, we take the PF ratio, if less than 100 is severe disease, and we can see patient have hemodynamically instability, patient has altered mental state because of severe hypoxic, and those kind of patient we need to intervene intubation early, so to prevent the progression of the patients to a much more severe form of disease. And if the patient only fulfill the criteria of mild to moderate disease, in which they can still talk, the patient is not so tachypneic, patient's mentation is still maintained, then we basically can use the step up, the escalation of respiratory therapy based on the response of the patients. But to remember that monitoring closely for clinical deterioration is really important, especially look out for the possibility of silent hypoxemia, in which patient that you need to escalate the non-invasive to mechanical invasive mechanical ventilation. There are several types of patient that you need to think about failure, right? Number one, if they basically change in terms of hemodynamic status, they become unstable and they basically have a persistent high respiratory rate, and they basically have a persistent usage of accessory muscle. You can basically see the thoracoabdominal asynchrony, and by using the scoring index, in which the if you use the ROC score, it become low, and if the you use HACO score, if you use other strategy in which you use CPAP, HACO score higher basically tell you that the patient has a high likely of failure with an IV, and you need to escalate to early intubation approach. Therefore, the key point is careful monitoring is the key to safety. And point to intervene the patient for early intubation approach includes these 6 parameters. Number one, if the patient manifests as physical exhaustion after you start NIVs. Number two, if the patient have increasing respiratory alkalosis, you take the ABG and you see that the PCO2 rapidly drop, and this actually tell you that patient has a progressive tachypnea with increasing of work of breathing. And also in patient who basically you start the NIV and they basically have refractory hypoxemia, and you can see that you need to think if the PF ratio is much more lesser than about 150 or below, then you need to think to escalate the therapy to invasive mechanical ventilation. And if the patient develop any forms of multi-organ dysfunction, especially if the patient develop myocardial dysfunction and neurological dysfunction, think about escalation to invasive mechanical ventilation. right? Number two, as I said, prediction of the risk of an IV failure is really important so that you can choose to intubate the patient early. Right. One of the studies by Nicolini et al. In amongst the patient who develop acute hypoxic respiratory failure, you can see vast publication show that several factors that can predict the NIV failure. One of it, if the patient have a very low PF ratio, then you can see that worsening of radiologic infiltrate 24 hours after admission, and the patient who had high SOFA score index, and this correlates with severity of disease. And if the patient have hemodynamic change after several hours of initiation of the NIV, in particular, patient already started on the vasopressor, and think about an IV failure in that particular patients, that you need to escalate the therapy to invasive mechanical ventilation. Right. In correlation with COVID-19 in particular, I think there's not much different in terms of the factors that can cause, that can predict the failure of an IV. Okay, number one, you see at the disease severity. If you see that the patient have severe ARDS, in particular by Berlin's definition, if the PF ratio is less than 100, the patient have severe ARDS, and hemodynamically unstable that require vasopressor, patient who basically had complication of COVID-19, multi-organ failure, they have AKIs, they have myocardial depression, they have some form of the shock state, then think about an IV failure. And also in patient who basically have multiple comorbidities. Second aspect that you need to look and to predict the likelihood of the failure of an IV, the patient who has higher respiratory drive, meaning that clinically you can see that patient has a persistent tachypnea. That is why the RR is really important things after you start an IV. You need to not only looking the SpO2, but you need to see at the respiratory rate as indicator either the patient have a likelihood of failure or success towards an IV, or the patient who develop excessive inspiratory effort, worsening hypoxemia despite an IV. And also you can guide by the looking at the ventilator expired tidal volume. If there is high tidal volume, you know that patient have high respiratory drive. And the last one, you can combine with clinical monitoring, in which you can use a clinical prediction score. If the patient have low ROX index or high HACO score, this correlate well with the NIV failure. All right, we'll go one by one of the parameters. First, so we look at the severity. One of the study, Masika J et al., studied on about 600 patients with acute hypoxic respiratory failure with PF ratio less than 100. So the patient who basically initiated at first with NIV, about 40% progressed to invasive mechanical ventilation. They found out that the patient who basically have higher severity in terms of high simplified the SAPS-2 score more than 46, patient who develop severe hypoxemic with PF ratio less than 100, and patient who develop at least one of organ failure, especially if they develop shock state and if they have altered mental states. This kind of patient has high likely to have high flow nasal cannula failure, right? With regards of the NIVs, just now we see actually a high flow nasal cannula. Second thing, we look at the NIVs in a patient who has hypoxic respiratory failure. Similar findings has been found in one of the articles. The predictor of NIV failure include high SOFA score. This actually correlates with the severity of disease. And if the patient have worsening of the chest X-ray finding, involve bilateral lungs over 24 hours, and then if the patient develop tachycardia within 1 hour initiation of an IV, and the patient have worsening of the hypoxemia in which PF ratio in 1 hour after initiation of NIV is lesser than 150, and development of the metabolic acidosis after 1 hour of NIV, and this patient correlates well with NIV failure. And if you see at the specificity, it reach actually is more than about 80% up to 90% with the most specific findings to suspect NIV failure whenever a patient develop PF ratio in 1 hour after initiation of NIV is less than 150. All right. Second thing that we need to look for actually about the severity of disease that correlate well with the phenotypes. I'm sure that Dr. Aziz already spoken about these before. It's just to highlight back and recap back. we have two types, the L type, the H type. Most of the patients that come to emergency department actually fall within the L type, and those kind of patients have very high lung compliance. That is why recommended support actually is to start an IV if they are hypoxic, right? In other extremes of the disease, which is a typical severe ARDS, is H type. This actually only comprise about 30% of patients, and this patient actually have high elastance and low compliance. That is why they require invasive mechanical ventilation. That because we can recruit the lung in this kind of patient, they are PEEP responder. That's why we can give the higher PEEP using the invasive mechanical ventilation as the strategy for the respiratory support for this kind of patients. However, you need to understand that the L type can progress to H type. We are not really monitor the patient, and especially if the patient have a persistent tachy neck and respiratory effort is high using the NIV, this patient can progress from L type to the H type. That's why we need to do something for the high respiratory drive, right? Okay, then how can we know that this patient have the L and H type? So I think it's quite difficult. Even the recommendation by the publication actually using the respiratory matrix to see at the compliance as well as the CT scan lung distribution. However, we somehow can gauge which patient basically fall in which category. Okay, let's say a patient present to emergency department with the chest X-ray is quite clear, or the opacities only involve the bases and also the peripheral. Not too bad, then most of the time they have a mild to moderate severity of disease if you calculate based on the PF ratio. And if the disease progress, what happened? The chest X-ray become more widespread involvement. You can see that patient become more hypoxemic, then it basically correlate well with the respiratory support that we basically opted to the patient. For example, in a patient who has a very bad chest X-ray, you start NIVs, and if the patient have persistently hypoxemia, you need to think that the L type become the H type, and you know that this kind of patient will progress more, and they basically will develop severe ARDS. You are not monitor the patient properly, and if the patient progress to severe form of disease, right? We can also use the lung ultrasound, as Dr. Azma say, in determine the severity of disease, right? How we use it, I'm sure that you already listened about the topic, the talk on the lung ultrasound, right? You can know that using the ultrasound, if you see that the lung abnormality, the lung pattern, that whenever you perform the lung ultrasound, you see the focal involvement of the abnormality when you perform the lung ultrasound with a low scoring system, we know that this patient have L phenotype of patient, and this actually correlate well whenever you see at the CRS, their lung compliance is nearly normal, and their PF ratio is not so bad. In comparison, if they basically have a phenotype H, we also can perform the lung ultrasound. Most of the time, they actually correlate well with higher last score. You can see from here just now, you have a last score of 11. Now actually it's become 27. And you know that the involvement and the distribution of the last pattern much more generalized. And this actually is consistent with CRS. You can see the lung compliance much more lower and the PF ratio much more lower as well. Right. One of the study by the D. Ellinger et al. That published in An Intensive Care studied on the lung ultrasound score to predict outcome of COVID-19 patient that come to emergency department. Very interesting. They found out that the last score of 20 correlate well with the patient who basically require intubation, and patient does not require intubation has much more lower last score, in which it's about 15 whenever they perform the scoring system. And you can see that the specificity and the sensitivity of using lung ultrasound, if the is about more than 90%, in a non-intubated patient, if less than 15, it correlates with a specificity of 90. In intubated patient, if the last score more than 25, it gives actually about the specificity about 93%, meaning that the higher the scoring system, the severe the disease, the high likelihood of the non-invasive ventilation failure and patient require intubation. right? And based on the study, also they found out that the last less than 15 correlate well with CT finding. If the last score is less than 15, it involves only less than 50% involvement on CT. If last more than 20, it correlates with a 50% involvement on CT. And if the last is more than 26, the specificity reach about 90% for mortality. If the last more than 25%, the specificity about 90% for the need of the intubation. Right. Second thing, as I said, the NIV failure, you can see at the respiratory drive. Whenever a patient was put on the NIV, you need to observe for the respiratory rate, how they breathe, how basically depth is the breathing, and either they use accessory muscles. Why it is important? Because of the vicious cycle of the lung injury. If you can see from this diagram, it is very interesting, interestingly to know that with higher respiratory drive, the patient will develop a self-inflicted lung injury in which they basically have high tidal volume. It basically will increase the transpulmonary pressure, especially in a mechanical ventilated patient. And the combination of the capillary leak, this in totality will lead to the lung edema and cause worsening of hypoxemia. And if you don't actually really intervene, the respiratory drive, whenever patient already started with NIV, what happened? This will cause a vicious cycle. The patient will develop more lung edema. The patient will progress to much more severe disease of COVID ARDS, in which they develop a severe form of ARDS. That is why some of intervention that you can do to start early NIVs to prevent and to obtain the respiratory drive in patient who actually is tachypneic and hypoxic. And if the patient remains high respiratory drive, you basically can start some form of opiates, benzodiazepine, and some of the protocols use a propofol, but you need to monitor the patient closely for the side effect of the drugs as well. But you need to, but better if you use a much more lower dose and titrate the dose accordingly to make sure that you can obtain the respiratory drive. Not so much, right? And based on the PCLE concept, you need to think of escalating the patient to the invasive mechanical ventilation in patient already on NIVs with persistent high respiratory drive. And if you can see from here, Marini JJ et al. In JAMA 2020 published a very nice diagram how basically the inspiratory effort does affect the choice of respiratory support. So if the patient of COVID-19 which come to emergency department in hypoxic respiratory failure, which is not respond to a low flow oxygen, you can start early the NIVs. And what you need to look for actually the respiratory rate, how the accessory muscle, either the patient use the accessory muscle, because this will determine the failure or success of the NIV. Let's say the patient have a persistent high respiratory rate, patient have a progressive to the severe hypoxemia state, patient using accessory muscle, think about failure of NIV and the patient require early intubation, right? And if you, how to know and how to monitor the respiratory drive, we know that in mechanically ventilated patient, there are some several parameters that you can measure. It's much more easier. You can use a PO1, you can use a maximum occlusion pressure, you can use the diaphragmatic activity measurement, you can use esophageal manometer to see at the pressure change. However, in patient who is a non-intubated, spontaneously breathing patient, it has a very limited things that we can do. However, we can use a clinical judgment to see that this patient have higher respiratory drive. For example, the patient has excessive inspiratory effort, they are tachypneic, they basically has high tidal volume based on the generated VTE from the ventilator monitor. So that kind of patient suggests that patient have respiratory drive which is higher, which likely require escalation of the therapy from NIV to the invasive mechanical ventilation. And not to forget that you need to also look at other aspects of the causes that can cause high respiratory drive and treat that at the same time, for example, patient who develop metabolic acidosis, patient who has higher temperature, patient, especially in patient who has cytokine storm, they basically have hypermetabolism and cause higher respiratory drive that should be treated as well, right? You can see in one of the study by the Benjamin and the group, so after initiation of the high flow nasal cannula in terms of the respiratory drive, they found out the improvement of the respiratory drive in terms of monitoring of the respiratory rate, the deep snake score, and usage of the accessory muscle and thoracoabdominal asynchrony. They actually found that the improvement noted to be as early as 15 minutes. You can see very drastic improvement of the RR, and also SpO2 improvement. And another actually is they basically also found that the improvement noted at 1 hour for PaO2 and PF ratio as well. And this actually really significant findings to say that this patient have high flow nasal cannula success. In comparison, the same study actually found that in patients who basically have a higher respiratory drive and worsening of oxygenation in terms of the SpO2 and PF ratio, this kind of patient actually correlate well with NIV failure. Therefore, in patient who basically has the persistent high respiratory drive with, in the absence of a clear reduction of respiratory rate and worsening hypoxemia, think about an IV failure and you need to escalate to the early intubation approach. We can see from here the black color code, the black graph, okay, black color graph. That is the NIV failure, in which you see that the patient who has NIV failure, most of the time they have higher respiratory rate and they basically have persistent thoracoabdominal asynchrony, and the PF ratio actually is less than 100 despite whatever NIV strategy that you use, and the SpO2 is much more lower to the NIV success group, right? And the other way of knowing that the patient have high respiratory drive, if you actually connected the patient to the BiPAP, for example, you need to pay attention to ventilator, in which if the patient has a good muscle, the ventilator provide a very good real-time information about the respiratory rate and also minute ventilation. Okay, let's see. The generated VTE actually is about more than 6 mils per kilo predicted body weight. Think about high respiratory drive. In this kind of patients, most of the time we need to intervene and basically to monitor closely and adjust the NIVs. And most of the patient, if they persistently have high tidal volume, think about escalation of the NIV to invasive mechanical ventilation. One of the study actually studied on the correlation of the VTE to the NIV failure. They found out that the patient who actually in a moderate to severe hypoxemic, the VTE was more than 9.5 mils per kilo, in which this was independently associated with NIV failure with specificity about 87%. And not only that, another study by Froehlich study, the VTE more than 9 mils per kilo was significantly associated with an increased mortality. That is why monitoring of the VTE is very important to know that this patient success or failure towards the NIV strategy. The third one actually is a clinical prediction score, right? I'm sure that you heard about it, the ROX index that we use in monitoring of the failure of success in patient who required high flow nasal cannula, right? Well, the study have shown that the ROX index more than 4.88 at 2 hours, 6 hours, and 12 hours correlates well with high flow nasal cannula success, in which an opposite to it, the predictors of NIV failure whenever a patient, when you calculated the ROX index, they actually fall within the low ROX index, less than 2.85 at 2 hours, less than 3.47 at 6 hours, less than 3.85 at 12 hours. I'm sure that this is quite difficult to remember, but I think there are a certain thing that we can do through, you can just Google and find for the perfect numbers from the online. And if you see at the ROX cut-off point at 2 hours, 6 hours, and 12 hours using the specific cut-off point, you see at the specificity of the ROX cutoff point is very high. It's almost 100%. That's why this actually can be used at the bedside as a tool to guide the clinician to predict the failure of NIV and escalate the treatment. So if we use this algorithm, for example, if the patient, the calculated ROX score fall, let's say, for example, the calculated ROX score at 2, at 6 hours, then you know that it actually fall within the red color coding area in which you should consider early intubation. For example, another patient that come to you, you calculate the ROX index at 6 hours, it become probably actually calculated at 6, then you need to just continue the NIVs and continue monitor the patient. That's how we use the proposed algorithm to guide our treatment. Right, this one, another example. Patient A basically on high flow nasal cannula at 12 hours, the patient have hypoxic respiratory failure with the ROX index of 3.12. We know that it is lower than the predicted cutoff point, and the patient you need to think about non-invasive ventilation failure and consider intubation. And another patient that come to you with high flow nasal cannula of 60 at 12 hours, and when you calculate the ROX index, actually is about 6, and this patient is more than 4.88 at 12 hours, then this patient most likely have high flow nasal cannula success. And another study is actually studied on the COVID-19 patient with ARDS. They use basically much more higher cutoff point compared to the previous validated study by ROCA. And the study have shown that high flow nasal cannula success using the cutoff point of more than 5.37 was associated with a lower risk of invasive mechanical ventilation at 4 hours. That is by the numbers by this study. And the second one, the second clinical prediction score that you can use actually is HACO score. Consists of the heart rate, the pH, the GCS, the conscious level, the PaO2 and PF ratio, oxygenation, and the respiratory rate. And you can use at the bedside tool for prediction of the NIV failure. Let's say you already started the patient on NIV, then you calculated the HACO score more than 5 at 1 hour of initiation of NIV. This study have shown that the HACO more than 5 at 1 hour associated with more than 80% risk of NIV failure, regardless of the diagnosis, regardless of the age, and regardless of the disease severity. Right? The same study, they use a cutoff point of more than 5, and you can see that specificity reaching almost about 85 to 90% using the cutoff point of 5. Right? I have another 2 slides to end of my talk. Okay, take home message. COVID-19 is highly heterogeneous disease. They can come to you with the milder form or severe form of disease. That is number 1. The response towards every respiratory support also different. Some of the patient respond very, very well. Some of the patient deteriorated and has NIV failure that should be escalate to the invasive mechanical ventilation, and some of the patient come to you with much more severe form that require intubation as the first respiratory support of COVID-19 patient. And the key point is careful monitoring is the key to safety. The sickest patient, think of NIV failure in patient with persistent or worsening hypoxemia despite NIV, persistent high respiratory drive, in which the patient have persistent tachypnea. Tachypnea, they basically have a usage of accessory muscle persistently, then think about NIV failure. And if the patient have altered mental states, high HACO score and low ROX index. And for the conclusion, this is only the guide for you to use at the bedside so that you basically can determine which patient actually fall in which category, right? Either NIV success and NIV failure. So think about NIV failure in which patient who basically have severe ARDS, in which we use PF ratio less than 100. If the patient have refractory hypoxemia with worsening respiratory alkalosis, in patient who has high respiratory effort, and sometime at the end of the at the late disease, they will have a shallow breathing, in which patient who develop altered mental states, in which patient who develop unstable hemodynamic throughout the NIV strategy, and patient who basically have the progression to the bilateral extensive chest X-ray opacity, the patient who has high last score distribution much more diffuse whenever you perform the lung ultrasound, in patient who basically have organ dysfunction, either the AKI, the cardiac instability, or any neurological dysfunction. And by using the ROX index based on the cutoff point at 2, 6, and 12 hours, if it is low, then think about an IV failure. And the last one, if you use the CPAP or BiPAP, we can use HACO score to say that this patient have an IV failure, in which think about an IV failure if they basically have high HACO score more than 5 at 1 hour of the NIV. So I think that's all for my presentation. I think before I end of the presentation, I would like to just say thank you to all frontliners and our heroes for all what you did so far. You actually is a very great clinician. I hope you can continue the good works. And then with that, and thank you. If you have any question, you can put in the chat box, then we will answer later. So after this, we will have our last talk of the day on NIV for COVID-19 in emergency department on the topic of how to win NIV in COVID-19 patients. That will be given by our dear emergency physician from Hospital Raja Permaisuri Bayanipo, Dr. Cheong Chi Yin, and he also is a fellow in emergency critical care and also obtained his fellowship in WinFocus, critical care WinFocus. And without further ado, I would like to invite Dr. Cheong to the platform Zoom, and you can continue with the next presentation. With that, and thank you.
Good afternoon, everyone. Thanks for still remaining in the webinar. We are quite behind time. So I will be sharing about the winning from NIV in COVID-19. Is the last lecture in this webinar. From the previous presentation, we already know appropriate use of NIV reduces intubation rate in COVID-19 patient. But similar to invasive mechanical ventilation, the duration of NIV support should be minimized. It is to reduce the complications that have been mentioned by the previous speaker. Winning is the process of discontinuation of NIV support to the normal conventional oxygen therapy. And if a success is defined if we can get the patient off the NIV to normal or conventional oxygen therapy for 24 hours and the patient is remaining stable. Although it is easier to withdraw the patient from NIV compared to invasive mechanical ventilation, but have to bear in mind that there is still complications from inappropriate withdrawal of NIV. And the weaning process should be considered once the patient's condition improves. And the first step is to screen or to assess if the patient is suitable to be weaned off from the NIV. So what are the weaning strategies? Even in condition in which the NIV use has been practiced for many years and with some good evidence, for example, the COPD, the weaning strategies is yet to be established. In general, we can do the weaning, either we can do it to an immediate withdrawal or a stepwise weaning. So, of course, there is a pros and cons of these two general approach. If we withdraw immediately, so we can have a considerable shortening of the weaning process, but there is the risk of failure and at the need for reinstitution of NIV if failed. If we do a stepwise weaning, we can minimize epileptotrauma and we can gradually increase the respiratory muscle strength of the patient. But this may take unnecessary prolonged time for weaning. So let's go through some evidence on the use of NIV in other common conditions. And then we see what information or the strategy we can extrapolate it to COVID-19 patient. So Lun et al. Has done a study comparing the stepwise withdrawal to immediate withdrawal NIV in COPD patient. So they found out the rate of successful weaning were higher in a stepwise weaning compared to immediate withdrawal strategy. But this is statistically not significant. Nevertheless, the British Thoracic Society and the Royal College of Physicians recommended, based on this result, the study result, recommended a protocol using stepwise reduction in NIV, which takes about 4 days of weaning in COPD patient. Another group of researchers comparing 3 strategies of withdrawal from NIV in COPD. So what they did is they divide the patient into 3 groups. The first is they practice what is called by stepwise reductions of NIV. In this group, they gradually increasing the NIV free interval over a few days, approximately 2 to 3 days. The second group, they stepwise reduce the pressure support gradually, and then they remove the NIV once the IPAP is about 6 to 8 and the EPAP is about 4 to 6. And the last group is immediate withdrawal. They immediately withdraw the NIV support once the patient is stable. And the result of the study show that there is actually no significant difference in the probability of successful withdrawal. Again, this is in COPD study. What about protocol directed weaning strategy? To win a protocol, is protocolized weaning strategy better for weaning? And then this Tuan has conducted a protocol directed versus physician directed weaning study from non-invasive ventilation. And what they found out is protocolized weaning strategy reduce the durations of NIV and also reduce the durations of ICU stays. Okay, now what about COVID? From the previous lectures, we come across a lot of recommendation, but you can see that recommendation, most of the guideline on COVID-19, they provide on NIV, they provide the recommendation on the indications of the use of NIV, how to deliver the NIV, and the safety issues. So there are not many studies talking about the weaning strategy. And most of the recommendation or the suggestion were based on the previous experience of other viral pneumonia. For example, the Florida study. And use of NIV in pneumonia has always been controversial. So how do we win in COVID-19? Basically, there is no general consensus. The weaning from NIV is carried out depending upon the individual choice of the intensivist. Why it is so difficult to get guidelines on weaning in COVID-19? I think because there are a few reasons. The first thing is because until now, we don't fully understand about COVID-19. And then there's also existence of different phenotypes of COVID-19 induced ARDS as mentioned by previous lecture. The evidence on NIV weaning is very scarce. And then the recommendations are being changed from time to time. And the last reason I think of is there is a regional difference on resources and individual preference or center preference on different types of NIV usage in NIV in COVID-19. But we still have to have some strategy to win NIV from COVID-19. So generally, once the patient fulfill the criteria for weaning, so we will start the process of weaning. So what are the criteria? Generally, the patient respiratory distress need to improve. So the respiratory rate has come down. The guideline, the suggestion recommended 25 to 30. The saturation should be more than, medium volume is more than 94%, ranging from 90 to 96%, with the FiO2 less than 0.5 and PEEP less than 5 if the patient is on CPAP. In certain group of patients, for example, patient with chronic type 2 failure, the target SpO2 may be lowered. So usually we take about 88 to 92%. And then PF ratio more than 200 to 250 is also one of the criteria suggested in the literature for weaning. So first we go through how to wean from high flow nasal cannula. So similar to the evidence on NIV, most of the study are being conducted to determine how to deliver the high flow nasal cannula and what clinical setting it is useful for. The best strategy for weaning from HFNC is still unknown. There's one study looking into the weaning protocol for high flow nasal cannula, but this is a pediatric study. It's conducted in PICU. And in this study, the patients recruited is all the patients that require an HFNC for any indication. What they did is they assess the patient using what they call respiratory assessment score. In this score, there are 6 parameters, and each parameter they give a score from 0 to 2. So the maximum score is 12. So and then they suggested what they call high flow nasal cannula holiday protocol. So what they did is, if they assess using the RS score, if the RS score is less than 7, they put the patient for the holiday protocol. They lower down the flow, but maintain the FiO2, or even increase the FiO2 to keep the desired SpO2. If the RAS score is 7 to 8, they reduce the flow by 50% and titrate the FiO2 to keep keep the desired SpO2. If the RAS score is more than 8, they wouldn't wean on the day, and then they will assess in the subsequent session. So in this study, they found out using this holiday protocol, 90% of the patients can be weaned within 4 holidays attempt, and 70% patient can be weaned successfully with only 1 holiday attempt. And patients who fail the first weaning attempt require longer durations of high flow nasal cannula before the next attempt. Again, this is a pediatric study. It may be difficult to extrapolate to adult patients with high flow nasal cannula. In a recent paper by this Wing et al., so they proposed a weaning protocol from HFNC. First, they reduce once the patient fulfill the weaning criteria, they first reduce the FiO2 by reducing the FiO2 0.1 every hour until the FiO2 is 0.4, targeting the SpO2 92 to 98%. And then only they will start reducing the flow with the rate 10 liter per minute every hour until the target of 20 liter per minute. So once the patient remains stable with the FiO2 of less than 0.3 and the flow less than 20 liter, so they will wean the patient from the high flow nasal cannula to conventional oxygen therapy. So this is protocols proposed by the author. Actually, currently there are randomized control trial starting at 3 different protocols. So what is called a slow trial. What they do is they recruit the patients who require high flow nasal cannula for any indication and fulfill weaning criteria. And then they divide this group to 3 groups of different intervention. The first is they reduce the flow first. And then the second, they reduce the FiO2 first. And then the third one, they reduce the FiO2 and the flow together. They are looking at the time to weaning, the success and the failure rate, the change in the blood gas, the intolerance rate, hospital length of stay, and the in-hospital mortality. So this is the flow chart of the flow trial. So basically what they did is, if the flow reduction group first, they reduce the flow with the rate of 10 liter per minute every hour until 20 liter per minute. Then only they reduce the FiO2 with the rate of 0.1 per hour until the FiO2 0.3. The second group on the FiO2 reduction, they reduce the FiO2 first from at the rate of 0.1 unit per hour until 0.3. Once it's achieved, then they start to wean the flow by 10 liter per minute per hour until the flow rate of 20 minutes. Then the third group is they reduce both the flow and the FiO2 at the same time. And then they will look at the outcome. So the result of this study may be able to suggest a better strategy for hyponasal cannula withdrawal in the future. So next, moving on to weaning from CPAP in COVID. In a paper by this author on the use of helmet CPAP in COVID, this management strategy is proposed. As the patient reaches clinical and respiratory stability, they wean the patient from helmet. So they reduce the PEEP and the FiO2 until the target of FiO2 not more than 50% and the PEEP is less than 5%. But how fast and how aggressive to bring down the PEEP support and the FiO2 is not mentioned. Okay, and then again, once they reduce the start weaning, they monitor the patient in terms of the PF ratio and the clinical parameters of respiratory respiratory distress. In a recent narrative review of use of helmet CPAP in COVID-19, just published a couple of months ago, so a quite similar protocol is proposed. So the author proposed to wean first by decreasing the PEEP and the FiO2, targeting the PEEP less than 5 and FiO2 less than 0.4. And then they increase the helmet CPAP free time. And if the patient remains stable, the respiratory distress is not worsening. So they will replace the helmet CPAP with conventional oxygen or hyponasal cannula. But individualized care is emphasized in the proposals based on the comorbidities of the patient and the resolutions of the respiratory impairment. Based on the latest available evidence, this Wing and et al. Has proposed an NIV algorithm involving the hyponasal cannula, the CPAP, and the BiPAP. So according to the proposal, the high flow nasal cannula can be weaned straight to the conventional oxygen therapy, and the patients on CPAP or BiPAP may be weaned straight to the conventional oxygen therapy straight, or to high flow nasal cannula first, then only to conventional oxygen therapy. So this is a summary of the proposed algorithm. It's quite similar to other suggestion by other author. So if the patient is on high flow nasal cannula and they remain stable, so they will start weaning the high flow nasal cannula by reducing the FiO2 first, and then followed by the flow. If the patient is on CPAP, so they will reduce the FiO2, targeting less than 50% and the CPAP less than 5, with targeting the SpO2 above 94%. So this is basically what is being suggested or proposed by some of the authors. Lastly, it's about the monitoring during the process. We monitor the patient during weaning, as in when we are monitoring the patient when we just start the NIV for the patient. So what we are looking at, the PF ratio, the SF ratio, the respiratory rate, and then the P-Sealy concept has been mentioned a few times. So basically, we want to avoid the patient to breathe with high tidal volume, with high inspiratory drive, because high tidal volume it indicates high respiratory drive, and this will increase the work of breathing. So this will cause a P-Sealy. There are some scoring mentioned, for example, hardcore score and ROX index. These scoring are originally not designed for to predict weaning, but is to predict NIV failure. But I think we may also use this scoring to monitor during the weaning process, to monitor whether the patient remains stable when we reduce the NIV support, and to decide whether the weaning process should be continued or not. So again, at all time, we need to look at the risk of the P-Sealy in every patient who is breathing spontaneously. So measurements of transpulmonary pressure is actually the ideal way to look at the risk of PCL. But in an NIV patient, this is difficult to quantify. So we may use other alternative ways by looking at the patient breathing effort. We can monitor the tidal volume if by using a CPAP machine or the NIV machine. So at last, some take-home message. I think the assessment of weaning should be initiated as soon as possible once the patient starts showing improvement. Protocolized weaning may be desirable to expedite the weaning. It is quite possible without a weaning protocol, so the patient will be kept on NIV longer than necessary. At the other end, if we are weaning too fast without a proper guideline of protocol, it is also likely that too rapid withdrawal may cause deterioration in the patient condition and increase the incidence of intubation subsequently. However, although protocol may help, but the weaning strategy should be individualized based on the patient's comorbidity and the respiratory support requirement individually. So, at last, despite the available data showing the benefit of NIV in COVID-19 patients, there are still a lot of uncertainty in the use of NIV, including what is the perfect timing to start, the perfect timing or the strategy to escalate and to win, and what are the best strategy to win. Although there are some proposed strategy which we can follow, but at the end of the day, I think as a clinician, we still need to individualize our winning strategies to patients based on our clinical judgment. With that, I thank you for your attention.
All right. All right, thank you very much, Dr. Chong, for the very insightful talk. So I think that's a wrap. Hopefully everyone has benefited from today's webinar. So on behalf of Ipoh Emergency Critical Care Society, again, we would like to thank all the speakers and all the audiences for joining our webinar of non-invasive ventilation for COVID-19 in emergency department. And we also would like to extend our thanks to KL Med Supplies for the sponsor. And hopefully we'll see you guys again in near future. Till then, stay safe, stay healthy, and stay strong. Bye-bye.